So I'd like to welcome everybody to the second session of XLH Day, the so-called rehabilitative session, and this is really exciting for me. It's an aspect of XLH that hasn't been addressed in the past couple of XLH Day events, and I'm particularly excited because this is an area of a disease like XLH which is often neglected. We know the therapy, we know the medicine, we know the treatment, but yet there's this whole other aspect of the disorder which includes significant mobility and pain issues. And that really speaks to quality of life. So in the second session today, we really hope that to gain a better understanding of the sort of quality of life issues that you can address, both from an occupational and physical therapy approach, and also about how the health profession team works together, including folks today here from nursing and the physician's assistant program, so that together they work as a team to benefit you as the patient. I'm going to allow the panelists to introduce themselves, and but they're all amazing. And I've been very, very lucky to be situated at a school where we have so many wonderful people that can really speak to these issues today. And we also have a guest, Christina L from Yale University, who is a physical therapist who has worked with patients with XLH, so she really brings a lot to the table today to contextualize everything that you'll be hearing. So I welcome everybody, and I think I'm going to turn it over to you guys and put my feet up. Thank you.
Do you want us to just go across and introduce ourselves? Kind of left to right, does that make sense? I'll start. Hi everybody, I'm Karen Myrick and I'm a professor here in the School of Nursing. I teach both in the undergraduate, the graduate, and the doctoral program. And I see patients in Avon, Connecticut, where the majority of my patients that I see are orthopedic and sports medicine patients, but I also do some primary care along the way as well.
Hi, thank you, and thank you for inviting me. I'm Dennis Brown. I'm a professor here in the physician assistant program. I've actually 25 years worth of experience in primary care and emergency medicine, and recently joining the faculty here. So I bring a lot to what I'm going to talk to you about today is a little bit more about the primary care, the changes in PCMH and the Affordable Care Act and things like that, and how it'll affect you. And turn it over to
You saw me earlier this morning a little bit, briefly. Again, my name is Dr. Keith Steigbigel. I'm a physical therapist, and I do work part-time at the university here, working with the physical therapy department, the graduate students, right now specifically with the gross anatomy aspect. But I've been an orthopedic physical therapist for 15 years and exercise physiologist prior to that life. So I have a practice called Quinnipiac Physical Therapy. No connection other than the name. It's in this region, and we see majority of your orthopedic adult and adolescent issues that very much closely relate to what we're talking about today.
Hi, I'm Christina L. I'm a PT at Yale New Haven Hospital. I am for 27 years. I've also practiced in birth to 3 settings and home care settings in pediatric therapy. I am a member of the XLH team at Yale New Haven, and so I'm happy to be here to talk about issues specific to this disorder. Thanks for having me.
Hi, my name is Julie Booth. I'm a physical therapist and a professor here in the PT department. My primary areas of expertise are in pediatrics and adult neurology. I also, in addition to being here, I work in the Glastonbury Public School System as well as Connecticut Children's Medical Center.
I usually have a big enough voice, but he's recording. My name is Tara Glennon, and I am a pediatric occupational therapist doing this for almost 30 years, but I really hate to say that. I have a clinical practice. I have an office both in Fairfield and in Wallingford called the Center for Pediatric Therapy. In addition to that, I've been teaching here at Quinnipiac since 1990. So I've been here a very long time. And again, I don't like to say that because my students now haven't been born, you know. Like I teach a class and they weren't born when I graduated from Quinnipiac, so.
Hi, I'm Katie Meriano. I'm the current chair of occupational therapy here at Quinnipiac, and I practice in an outpatient setting with primarily adult neuro and orthopedic populations.
I think I'm the caboose, right? I'm Roseanna Tufano. I'm also a professor in occupational therapy. I'm also a marriage and family therapist, and my area of practice since 1980 has been in mental health and psychosocial dysfunction. So I'm very happy that Carolyn has invited us to be here today and look forward to talking with you more.
Thank you.
Well, thank you. Karen and I are going to get things started here, and what we're going to be talking about is a little bit about the actual care team and how the care team under PCMH and the new Affordable Care Act, how we interact, how we get people in through the offices and out into the actual physical therapy, and some of the things that you'll be looking at and how to advocate for some of the things through the offices is what we'll be looking at doing here. And we're going to do this all in about 5 minutes for us. So put your seatbelts on. So who is the patient care team? You know, a part of the whole total care team under the PCMH is starting off, and if I use any acronyms, please feel free to ask me. PCMH is a patient-centered medical home. It's a part of the Affordable Care Act, which I dub ACA, also known as Obamacare, for those of you who haven't heard of it yet. So anyway, so the primary care team really starts off with the primary care physicians, and they're pretty much deemed by Centers for Medicaid and Medicare Services as being those who are in family physicians, internal medicine, pediatrics, and OBGYN. Then on top of that, you'll have the subspecialties. They're not primary care under these. And we're going to talk a little bit more about that as we go on, about you know, how they could be if you used them. So under them, the part of the team approach then also includes physician assistants, nurse practitioners, whether APRN, DNP, I know there's several others, FNP, the nurse practitioners. So then also a part of that team includes occupational therapists, physical therapists, the social workers, the diabetic educators, and then even on expanding out the team a little bit more could include acupuncturists, chiropractors, and licensed massage therapists if they become a part of that team. To give you a little visual on how it works and how this team goes, the patient-centered medical home is centered around you. You as the patient. It's designed to provide more quality, and better access to care, and really it all revolves around you. And really this slide is great, but if you really wanted to draw the lines correctly as to how they all interrelate, we would have spaghetti on that slide because everybody talks to everybody in this team. And that's the way it's designed to do. And it's designed that way for a specific reason. It's designed because we want to increase the quality of care that's to you, increase the access and how quickly you can get in that access through the use of patient navigators. In my office, we brought in patient navigators. They were the ones who would take the referrals from us as the providers and make it happen. They would make the phone calls. They would be calling around instead of just, okay, you got to call somebody or waiting around for a letter to go out. That was their sole job, doing that, getting people in, getting the follow-ups. So that's really PCMH looking at that, also looking at lessening the costs with inappropriate testing, inappropriate ER usage, and reduction of medical errors, which is a big thing. And a lot of that comes from medical records and getting the records back and the quality and the follow-up care, and also coordinating the care. How many of you see more than one or two specialists? About a lot of you, right? So if we don't have one person, the primary care team, following this, you can have one specialist prescribing one medication and another one prescribing another, and they're not talking. Now we've got interactions and we got problems. Or they don't know that, oh, you've already seen or had this test. We need to get that. So that's where we get the whole coordination of care, and that's where the whole PCMH part comes in. So as somebody with a chronic disabling disease, you have increased needs that are addressed a little bit more by the PCMH as we look at this. This is just a small list of all your needs. And you think about how PCMH and the Affordable Care Act would work with this, increasing your ability to get in to see these specialists, increasing the ability to get more therapies, access to trials, getting the know of those and being able to get into it. So really, if we look at the patient-centered medical team, we actually have to look at it as a little bit broader scope when we're talking about chronic disabling diseases. And this becomes more the patient-centered medical home neighborhood. The neighborhood includes the primary team plus more of the subspecialists. I'll talk in a moment here about, can your PCP be, or can your specialist be your PCP? But for the most part, this is where we're going to be getting in and get interaction. The arrow between the two means a dual-way interaction, and we coordinate the things. Some of the things that, the myths that were out there about PCMH and the ACA that I think really are important to know, and the Institute of Medicine and the White House all put out all these wonderful papers debunking some of these myths. PCPs are not gatekeepers. This is not a big HMO. The ACA is not a healthcare insurance. It's just guidelines for an insurance companies and to coordinate insurance coverage and care. The government is not eliminating your choices. The benefits are not being slashed. Things are being coordinated in different ways. And the other big thing is there's an increase in coverage for children with the disabilities. A lot of you have children that have these syndromes. They can be covered under Husky and other medical insurances now at expanded ages and not cut off at a certain age. Now, the other question that we talked about a little bit before is, can your specialist, how many of you use your specialist as your primary care? So a couple of you do. Okay. Under the new regulations and guidelines, can this specialist be your primary care provider? The answer is yes, but the answer also has a caveat. If they want to do that, they also have to be the one who's going to take full responsibility for all your medical care, including your preventative screenings, including your sick visits, your sore throats, your sprained ankles, things like that. They have to be the one who's going to coordinate that. Many endocrinologists don't want to do that. Okay, it's out of their subspecialty. So a lot of them are going into the network and that neighborhood that I presented. They're forming alliances, whether it's through the Yale's networks or through Hartford networks or whatever. They're forming alliances so that they're talking a little bit more. The other thing is, if they wanted to do that, they have to follow a guideline, a pathway that the NCQA puts out to become a PCMH medical home. To be a PCMH, you have to then start submitting. There's all new ways that they're going to be reimbursing providers. You have to meet certain sub-thresholds. Have you had your colonoscopy if you're over 50? Have you received vaccines? Have you had your mammogram? And they start, and your blood pressure isn't controlled, and they start docking you if they're not. So as a primary care provider, that might be a real negative for the endocrinologist following you. So I wanted to talk a little bit more, switch over a little more to advocating for some of your needs and some of the things you can do in the provider's office. And one of the things, I don't know, Karen, if you want to jump in, some of the things some guidelines that I give are, if you're not openly discussing this in your doctor's office, it ain't going to happen. Let's be honest. If you're not talking to them and advocating, it's going to go under the wayside.
Yeah, everybody has unique needs, so letting your provider know exactly what those needs are specifically for you and your family then helps the healthcare provider to advocate for you to get those specific needs. It's not just a cookie cutter, you have XLH, so you need this. Everybody has different needs, so it's really important to let us know what you need.
Right. Yeah. And days like this are a great day for advocacy for you guys because you're going to know what other people are doing and what's going on with others and how things are working. And that's why these are just fantastic places. And one of the other things, don't accept your physician to be your primary care or your subspecialist to be a gatekeeper saying you can only go here or only allow this. Go for it, get it. It's out there. Insurances are reimbursing it. Sometimes there's a pathway, but they are reimbursing and there is a way to get it.
And as your president mentioned this morning, contact her or the group, because she has avenues that we aren't even aware of, and you can educate us as well.
Right. And one of the biggest things is this whole new change with ACA and PCMH is designed to be preventative and providing more preventative service, not preventing you from getting the care. That's really the thing. It's all a team approach. Oops. So some of the barriers we're seeing nowadays in the offices, how many of you go to your doctor and how long do they have with you? They got 10 minutes if you're lucky. And even then they're running a half hour behind. I am, and that's because I'm spending my time with my patients and I really don't care. They yell at me all the time. It is what it is. There's a lot of reimbursement issues on the provider's aspect. I mean, we can go down this whole list, coverages by insurances for things. It's really, and there's also a lot of cultural issues out there too. If you're talking, I work in community health centers. That's where my primary care has been. I deal with underinsured and uninsured. So getting them into care is often like pulling teeth. In fact, I think it would do better with pulling teeth than getting them into see some specialists. But, getting them in there and doing it, talking to your doctors. Now, kind of ending this part here is when I talk to my patients, when I actually educate our students, when we're talking about advocacy, there's 3 things you should end your visit, asking these 3 questions. And if you don't answer them successfully, then I don't think it was a good visit. And I actually changed my practice several years back when I went through a seminar where they were talking about this. And I actually asked my patients this at the end of the things, 99% of the time. Number 1, did you feel you got the best possible care? Did I give you what you need? Number 2, were all of your questions or concerns addressed? I don't turn around and ask them, you got any questions? Because that's the quickest way to say this interview's over. Any questions? Okay, that's precluding me grabbing the doorknob. So we ask them, did we answer fully all your concerns? Were they answered to your satisfaction? And did you feel this visit was a worthwhile venture for you? Did I waste your time or not? And 99.9% of the time I'm praying they're saying no, because I didn't. You're there for a reason, and that's what we do. So kind of summarize from us, we talked a little about the patient medical care team. We talked a little bit about barriers and accesses and the 3 questions, and I would recommend you, anytime you go to the doctor, end up walking out, whether it's your primary care, whether it's a subspecialist, ask those 3 questions. And if you don't get a good answer, then you should go on. Many avenues now with the PCMHs, portals to care, main hospitals are doing those, subspecialists. If you want to talk to them, there's portals to go in there, patient care areas you go in, send an email to your physicians, send an email to the team. There's somebody on that team that's taking them. My team consists of me, a physician, a nurse, a navigator, and a social worker, and that's all I have. Others have physical therapists on them, and others in that team. Anything else, Karen, that you wanted to?
I think that's it. Do you have any questions for us as the primary care team here today for you? Please. I think
we've only got 10 minutes per patient, and the patient's looking for everything that they want. I'm going to get that done in 10 minutes.
I'll start.
Okay.
Well, this is how we do it. One way that we can do that is with my patients, I get to as much as I possibly can addressing the very acute issues that day, and then I ask them to come back. Because you do only have 10 minutes and you want to give that patient all you can. We can also book, 10 minutes is just a term. We have 15-minute, half an hour appointments. So it really depends on the needs of the patient. This is where you advocate for yourself and we can also advocate for you is this gentleman needs to come back and see me in 1 week and I need 45 minutes with them. And it does happen if it's not an urgent care setting. So in a primary care office, that can happen. So we just need to know that up front. So sometimes it is a matter of having them come back. Or that is when you run the hour behind because I don't care what the schedule says, I'm there to get you what you need. So.
What do you think about email between visits?
Absolutely, and that's one of the things I was going to say is there's a couple things I do. Number 1, I want them coming with a list. We'll triage that list. We can take 2 minutes to triage a list of concerns and say, important, so the chest pain is a little more important than the fact you have a bruise on your toe. Okay, we can address those things first, but I'm not going to ignore that. let's set up a follow-up, let's bring you back, and let's talk about this other if it's something that we need to spend a little more time on. I also have them email. I used to have them email my MA and have them come in. And now with patient portals, as those are being set up, they have an access to send it in, and it goes into their chart.
And it's secure too, so
Yes.
there's no HIPAA violation, because that's always like you're not gonna, don't find me on Facebook, but, or Twitter, but yeah, no, it's absolutely appropriate through the portal. It's all set up that way for patient-provider communication.
And this way we get it, and if there's something that seems to be looming, we can have it already pre-addressed as I'm looking through the morning thing, saying, oh,
Yeah.
we'll want to talk to John about this. Anything else? Well, thank you.
Thank
you
you.
very much. Thanks for having us.
Okay, so for the next half hour, 40 minutes or so, the pediatric people will be chatting with you. And so I'm Tara Glennon, the occupational therapist, and Julie Booth and Christine Rayo are both physical therapists. And my job is to orient you to the types of systems and payment sources that are associated with children in general, and then talk to you about some of the specifics of your issues and how they interface with those systems. So, as we talk here this afternoon, we're going to try to outline some things, but we're also going to try to leave a few minutes for questions, because we know that some of this information is a little bit confusing depending on your specific issues. And as we start, the first thing that I need to say to you is, in pediatrics, many times PT and OT are sort of considered the rehab team or the motor team. And quite often you might get one person or the other. Chances are you won't get both. And sometimes it just depends on who's in the building when your child is in the building. And so we will talk about how it might overlap, and how then in the outpatient sort of medical world, our roles might be very different then. And as I speak, I'm going to talk in generalities for both PT and OT, okay? So the first thing that I just want to talk to you about, because people do know about this, is the Birth to 3 system. The Birth to 3 system is a sort of federally funded program to each state, and each state has its own rules about it. The difficulty with the Birth to 3 system is you have to be very impaired in 2 or more areas and have all of these bad scores on certain tests. It's our experience that the children that we're talking about here with this issue do not qualify for Birth to 3 services. They have a very specific issue that isn't impacting global areas of their lives just yet. And so they may not get Birth to 3 services. So I articulate that so that if I don't want you to walk away from this saying, oh, well, of course, then we should go get Birth to 3 services, because most often you will not qualify for Birth to 3. But in case people say it to you, you should know that it is out there, because many people will say to you, why don't you get Birth to 3? And you're going to say, I'm not eligible for it. I don't have it. My child doesn't have enough issues in several domains of his or her life. Okay. School-based services. In school systems, children are also eligible for federally funded physical and occupational therapy services, and they're funded under 2 categories. One is the Individuals with Disabilities Education Act, and again, that's a section that your children will probably not qualify under. However, under the American with Disabilities Act, what we call Section 504, anybody with a quote-unquote handicapping condition is allowed reasonable accommodations. So the way I sort of explain it is the same law that says Quinnipiac needs to put a ramp out front is the same law that says your child may need some help on the playground in their during recess or after lunch. So the children that we're talking about with the XLH, most of those children you would want to at least ask for a consultation either from the physical therapist or the occupational therapist. And to be honest with you, most often it's the physical therapist, unless there is no PT in the building on the day that your children are there, like in their preschool program or something, and then the OT might be there. So under Section 504, your child would be eligible for some PT or OT to come in and evaluate what the child's needs are in terms of accessing their educational environment. Are they safe on the playground? Can they manage the stairs? How did they perform in gym? Do they need some accommodations? And so because that is a particular area where the children with XLH get some services, Julie will talk about that specifically after I've done the overarching. The next area that we talk about in terms of places where you can find services that would be financially supported to you would be under your insurance coverage for an outpatient clinic. And we talk about the outpatient clinic providing a variety of different issues. One, if it's post-surgical and you have some immediate rehab needs, you might be going for PT. Two, if you have some particular life issues in terms of accessing the community or figuring out some daily occupations that aren't going so smoothly in the home, you might be able to get some support there. Christine will talk about the types of services that her experience through the Yale Specialized Services that children with XLH are getting, and the types of things that you also might want to be considering. Specialty clinics. So most large rehab hospitals or teaching institutions will have specialty clinics, and that's where Christine works, and so she will be talking to you about those types of services. And we're really talking about, this is the team of people that you're all familiar with. This is where you go to the hospital, you have your MDs, you have the whole team right there. And so that is the sort of fourth zone that we might talk about in reference to where you might access services. Okay, so that's our overarching. Birth to 3, you're probably not going to be eligible. Schools, you may not be eligible for direct services, but you could be afforded some accommodations and some problem-solving team of people around your child. Outpatient clinics, and then the specialty clinics. Okay, so I'm just going to quickly run through some OT concepts. Now, this afternoon, you're going to have Katie and Roseanna both talking to you about adult OT services. And so, as we know, each child is specific. So if there is something that Katie and Roseanna mention, but it's applicable to your child, then yes, the OT would be working on that. But I'm just not going to repeat all that because we have a lot of PT stuff to get to. So the role of OT. Can I just a quick show of hands? Who knows what OT is? Okay. That's good. Okay, so I get it all the time. Why do kids need a job? So what is a pediatric occupational therapist? Okay, we are talking about children's roles, their responsibilities, their routines, picking up a pencil, sitting up in class, buttoning a button. Any of those things, bending over to put their shoes on, tying their shoes, those are all of their jobs. To play is one of their biggest jobs. So if something is interfering with that play experience, then they would be eligible for an occupational therapist to come in and take a look. Okay, good. So the basic premise of occupational therapy is we say every individual has the right to participate fully in the meaningful occupations, aka jobs, roles, responsibilities, routines, in various communities, and each community is responsible for affording them the opportunity to do that. And children have many communities. The playground is their community. The YMCA pool is their community. And so all of those places we want to be able to look at, are they fully participating to an extent that they can? That's OT. Now, this is where it gets a little confusing because Julie's probably going to come up here and give you the same line. Okay, we are here to make sure that they participate fully. And so the distinction between OT and PT gets a little muddled. If it's a physical issue, which is the issue here, then there might be overlap. But more often than not, it's going to be PT. It's related to the legs, which is related to mobility and safe navigation of the environment, and that falls under PT. Okay, if it begins to impact how they play or how they can interact with their friends, then OT might be involved. But as I started in the beginning, most often PT. So in general, however, we want to be looking at, as occupational therapists, their participation in their daily activities, the buttoning, the dressing, all of those things that we mentioned earlier, as well as their classroom skills. So, this is not a big diagnostic area where I have a whole lot of experience, but I do have experience in problem solving. And so what we're looking at is if you are having an issue, and here's what I say to parents. During your day, if you find yourself saying, if my son or daughter could just do this thing, it would make my life a whole lot easier. Then I'd say, bring that up to the doctor and get to a therapist, because I bet you those therapists could problem solve, okay? So the therapist can help you figure out the better way of doing it. I talk about Sorry, I did this a few weeks ago. I thought I was 20 and I was lunging for a ball in tennis. I was not going to get it, but I tried. But I was this morning blow drying my hair with the hair dryer on the ironing board, sitting on a chair with the floor mirror in front of me doing my hair. It's just coming up with how can we get you and your children able to participate more fully and gain some independence and mastery over the skills that they're supposed to be mastering. Okay, all the way down to how do they carry the backpack? How is it fitted? What's the weight supposed to be? Okay, many, many minute details of participating in life. So we're talking about for OT promoting functional abilities. And modification, adaptations, accommodations is sort of the big words for this diagnostic group. Supporting the participation. Okay, so because school system and clinic medical services are so intricate, both Julie and Christine will discuss those for you.
So Tara did, there will be overlap, hopefully not a lot in what we talk about, but PTs and OTs within the school system themselves, there's a lot of overlap, and there's a lot, we use a consultative model frequently, especially with children that are on 504 plans. So I may be seeing a child for physical therapy, but I'm always consulting with the OT. What are your thoughts? How can we do it better? And then consulting with the teacher as well. And I think that's really important to think about within the school system is it's not one discipline. It's not just physical therapy working with your child or occupational therapy working with your child. It's a collaborative model. So we may go in and we will say something to the teacher. If there's a paraprofessional in the classroom, we'll discuss something, but everybody's involved in that, and that's really important within the school system and something to keep in mind when I'm talking about physical therapy in a school-based model. The primary role of a physical therapist and occupational therapist within the school system is to promote that independence. So you have a child in school who maybe, because of their XLH, it's difficult for them to sit in a chair. They're sliding down the chair, they're leaning on the desk, and the teacher's like, they're not paying attention in class. I think they may have issues with attention, or maybe they have ADHD, but you go in the classroom and the child can't get their feet on the floor, so they're not supported. Well, all you do is you put a box underneath their feet, and their whole demeanor changes, right? Now they're not so fatigued trying to maintain their posture in the chair that they can't pay attention. So sometimes something just small like that, and now the child's able to pay attention in class, they're much more independent in their work, the teacher's not having to be on them all the time, get your head off the desk, and so just something small like that can really make a big difference for a child. And that's all part of promoting the independence. You may have a child also that they're riding the bus. Well, that step from the ground to the bus is really big. For a kindergartner who's not short in stature, that's a huge step. So what can we do to help them get that independence? Sometimes it's just, again, putting a step on the bus. The bus driver has the step. They probably won't put it down for the child, but another child can do that. So you put it on the ground, and you may put it on each step. So the child then independently can get on and off the bus, and they no longer have to take a van to school. Because sometimes they will do a van because the child isn't safe getting onto the bus. So it's just all those things that, they can just be little. And the same goes for increasing participation in the home and the community as well. What can we do to make the child be able to access their community? So say that they have the neighborhood is out playing and they're running, and your child, unfortunately, running can be really hard for children with XLH. Can be short in stature if they have the bow-legging. A lot of times they'll have in-towing as well, so they're at higher risk for tripping and falling. But you want them to be able to participate with their friends. Well, what can they do? What about using a bike? If the friends are running, or using a scooter. And the scooter is nice because if you switch legs and their foot straight ahead, it's limiting some of that in-towing. But what's out there? What's fun for them to do that can let them interact with their peers? And as a child, to me, that's one of the most important things, right? You want them to be able to interact with their peers and to participate with their peers. At home, what can you do? If you have a child at 5, typically developing child without any limitations, they should be able to walk up and down the stairs in your home. a child that's short stature, that's really hard. And it has nothing to do with their abilities. It's how high the steps are, right? So it's okay that they crawl up and down the stairs. It's fine. Just thinking about those things for your child, and thinking about when you're out in the community, give them extra time to get places. It's harder for them. Their steps are smaller, if they're short stature. Again, they can be higher risk for tripping, but just be thinking about allowing extra time so they can do things on their own. And it's also okay if they get tired that, maybe you put them in a stroller, and that's okay, just to try to let them participate as much as possible. Physical therapy also will work on motor development and function, but typically children with XLH don't have issues with motor function. Their motor planning, figuring out how to do things is really good, and actually they could be really good problem solvers because they've had to be. So we're not really necessarily working on that, the motor development, but maybe helping with function, again, trying to make things as easy as we can for them. Physical therapy can be involved in strengthening. Sometimes these children tend to be a little bit weaker because they haven't been able to be as active. So weaker and a little bit working on their endurance as well. And for the endurance, it is finding those things they can do for extended periods. So riding a trike is a great opportunity. We have some items over there you can look at later, but even, sitting on a scooter, one of the seated ones, sitting on it, pulling with their legs, doing a roller racer that has arms and it's all their upper extremity movement to make it go. Bouncing on a ball, activities that are building endurance, but without having to be running per se. Within the school system as well, enhancing learning opportunities. Most of the time, your children wouldn't need assistive technology. When we think of assistive technology, there's a wide gamut for that. It can be everything from a pencil grip for a pencil to help them hold the pencil better, all the way up to using some computer devices or switches for them to access the curriculum. But it also can be just equipment. So kind of tying into the promoting health and wellness, for a student within the schools, and they have PE, and a lot of times with PE, it may be hard for your child to completely participate in that. So it's important for physical therapists and occupational therapists within the school to help the PE teacher adapt what the program is. So again, if they're running the mile because they're doing fitness testing when they're in 3rd grade and your child's not able to do that, well, is there a bike that they could ride around the track at the same time the other kids are doing that? What can we do to adapt it? And also, it's really fun when the other kids see that happening, they want to do it too. Your child now is special because they get to do this. They get to ride a bike in the hall at school, and then they can invite a friend. And it makes it, it's more accepted, and, the other kids are actually a little bit jealous of, they get to do these special things. But being sure that, they're doing it all with their peers. They're not isolated. They're involved in everything that their peers are doing. I also put in assisting caregivers here, and that can be, family members. It can be people within the school system, just so that they have an idea of what may be hard for your child to do, and they're thinking ahead. And again, it's that collaborative approach. It's the teacher, it's the paraprofessionals, it's the person that's, the school bus monitor that's watching them getting on and off the bus, making sure they know that step needs to be out there for the child to get on and off the bus. And I touched on this some, we do a lot of collaboration within the schools, and I think generally in all venues that PT and OT are offered, it is a lot of coaching. And I know Chris is going to talk about that for the outpatient and the specialty services. But it is coaching. What can you do for your child to help them? Not coming to physical therapy on a regular basis to do strengthening. What can you do at home? How can you work with other members in the community? If your child wants to do basketball, who's a basketball coach? What can you do to help make sure that your child is able to do that? And also looking at things within the community that they're going to be more successful at. I think that Chris will touch on this a little bit too, but, swimming might be a better alternative than football. Just thinking about that, what can your child do and what opportunities are out there? So that goes along with safety in the home and the community. Safety in the home, because there is a risk of falling, because a lot of times with the in-towing, just think about that. Think about things that you have around the house. Just making sure you're aware for your child. Doing the stairs, that's hard. Again, crawling up the stairs is a safer approach to the stairs than it is to walk up and down. Just providing families with information about what the needs of your child may be as they're moving through different developmental sequences. And helping families with transitions. There's a big jump from elementary school to middle school. What can we do to help you with that in that transition? So now the child may have to go up and down stairs when they're in school. They're switching classes. What can we do to help? Can we send home an extra set of books? So your child's not carrying this big backpack that weighs twice as much as they do sometimes, I think. They're not having to do that. Can they have access to the elevator? If things are a little bit harder for them moving around the school, can they get out of their classes 5 minutes ahead of time? But thinking that all through before the child actually goes to the school and maybe has issues, you want to prevent that before it happens. And then physical therapy gets involved in terms of the hospital and the clinic. So care for any medical conditions, looking particularly surgically, and Chris is going to go into that a lot more. But post-surgically, physical therapy will get involved with your children, especially, frequently osteotomies are performed, and what do we need to do pre and post for your child? Chris, take over.
I'm just going to make one comment in reference to, because so far we've been saying modification, adaptation, accommodation is a big issue for children in the school system. And the one takeaway, if you could, from this is really thinking about what is ultimately important for that child at that moment in time. So, for example, Julie just said, could they take the elevator? Some might argue take the elevator saves the energy so that when they get to the whatever activity it is, they're not exhausted, they're there to fully participate. Some might say, no elevator, take the stairs, get the exercise, strengthen. Either is fine as long as everybody has mutually sort of collaboratively decided, at this moment in time, I think exercising is the most important because they're going to something where they're just going to be sitting doing something or resting or it's library time. Whereas taking the elevator on other days might be the priority because when they get there, you want them to have their stamina, their strength, and not be exhausted so they can fully participate in that task. So either is fine. And different people have different viewpoints, but as long as everybody's really looking at this moment in time, what do we want this child really to be doing? What's the primary thing? So that would be my takeaway.
And can I just ask one question? So those accommodations you were talking about, they can all be implemented as part of the 504 plan for that child? So that would become a documented mandate then?
Correct. And it's something that would be done annually, every year, and you would meet as parents, and depending on the age of the child, sometimes the children are included as well, but you would meet annually and discuss those accommodation modifications, and those are provided to everybody that interacts with a child within the school system. And I will say that Tara had mentioned the IDEA, so services can be provided under that, but the children that qualify for that are children that have special education needs. So if your child does not meet the criteria for special education, then it would go under a 504 plan. And direct services can actually be provided under a 504 also. So for example, if your child is post-surgical, returns to school, some direct PT services may be provided to help them, using the bathroom, if they're on crutches, making sure that they're safe and working with mobility for them. But under a 504, typically, those are short duration direct services that are provided, and it is more of a consultative model.
With that, there is a little tiny loophole in the educational sort of 504 world, in that it's the child's school and participation, and there's this sort of global line. And I share this with you because I think it is also appropriate for you to ask for some sort of consultation, maybe to the town's park and rec activity that you have allocated your child to participate in. And the school, they're not going to provide you services out there, and they're not going to send everybody out there, but they may provide someone to go out once or twice to meet with the coaches, to share some of the suggestions and strategies and accommodations that would be appropriate. And The card I always play to keep them safe. Parks and recs. You don't want this child breaking their leg on your whatever, first base. So it would behoove everybody to have someone come out and just problem solve a little bit.
Sorry, I'm going to add one more thing. As we're talking, we will let Chris talk. The school also has to provide the same services for extracurricular activities that are sponsored by the school. So if your child has a modification during the school day or accommodation, that also has to be provided if they want to participate in the play or anything that's school-sponsored. The school is responsible for providing that. If your child needs special transportation to school, that they are taking a van, and they want to participate in extracurricular activity, the school is responsible for that, for providing that. It has to be school-sponsored, and you may have to fight for it, but that is part of.
Sorry, we're chatting.
But all right, it's a perfect transition into where I'm going next, and in particular, Tara's comment about having the activities be selected as which are priorities. Is climbing the stairs with one's peers the priority? In which case, the elevator is not elected. But if preserving energy for attention in the classroom and participation once the child arrives at the classroom, then the elevator is a good idea. And those are active decisions on the part of the child and the team. And those become lifespan questions and lifespan issues that we find with the youngest children. It's the act of climbing the stairs that is strengthening, and it is their job at that age to develop those gross motor skills, to learn to climb the stairs. And so that is a choice that we make for our toddlers and young children. Flash forward across the lifespan to a student attending high school or college or entering the workplace. The world is much bigger. We are much more likely, that individual or those advising that individual are much more likely to look in the direction of adaptive equipment, perhaps, to assist a person who has knee pain or has limited endurance, to take advantage of assistive devices to get where they're going so that they can perform their job or participate in a college classroom. And that's where we're going to go now. So I'm going to talk about physical activity in XLH, kind of across the, starting in childhood and approaching adulthood, and then come back to the role of physical therapy with that. So with young children, we're going to meet you in the specialty clinic, and we're going to talk about how that child's daily activities could be supported. There's not likely a need for direct therapy for many children with XLH in young childhood. It's more supportive care, being patient with the patient in terms of the medical treatment and waiting for a response to medical treatment, in terms of addressing the bowing and the torsion and the stature issues, adhering to that medical plan, the medical regimen, I should say, and keeping the child active on that child's own terms, that child's own proportions. The motor milestones might be a little bit delayed, as Julie was mentioning, that just because of stature and because of the mechanics of the joints and the bowing, but the motor patterns are there, and so the skills will emerge, just on a slightly different timeline. Loading of the bones is important to help the bone density progress. It's those forces that promote bone density in combination with the medical regimen, but also there are joint stresses associated with bony loading. With the young people in the room heard me speak this morning about using the example of the femur bone and the femur and the tibia. When the bone is straight, the bone is loaded. The forces go through the axis of the bone, and the knee joint is relatively not stressed. But when you have a bowing, then there's a gapping at one side or the other of the joint, And those forces, we use drinking straws, flexi straws, to show that. And when we have a flexi straw held straight and we push down on it, the flex doesn't give in either direction. But when we put a bend or a curve into that flexi straw and then we load it, then it bows out to the side further. And so that's an example of how the joints, the knees in particular, are stressed when there's bowing in those two segments. And so respecting the mechanics of the body, particularly at the knee, is important in young childhood while we're waiting for that bony response to treatment. Another is the torsion that is very much a component, or the torsion or the twist of the bones, often in the lower leg that sets the foot often inward. Respect of the mechanics that are involved there is important as we do things like choose shoes for our child who is trying to walk and clear one foot from the other during a gait pattern when there is that bowing and that in-toeing in combination. So we are looking for large muscle activity to build strength and build endurance, so looking for opportunities to be active. Tara mentioned about running and how running may not be the ideal activity to protect those knees, at least running distances. So climbing and swimming and cycling and different types of toys are tools. It's lovely. It's a lovely thing to find that for young children, that the toys that are inherently part of childhood are also therapeutic for young children with XLH. And then that continues actually as they get older. And here's, many of you are familiar with looking at x-rays, but this shows the bowing and the bony surfaces and the growth plate surfaces that are rather uneven and not as mineralized as they would be otherwise. And so this is what I was referring to when I was talking about the forces that the joint and the bones are withstanding in early in XLH with the bowing that is characteristic. So to sum up, the milestones, developmental milestones in young children, particularly regarding elevations, things like stairs, can be a little bit delayed, but they do progress. We're looking to balance the loading activities and the less loaded activities, so a little bit of running, but a little bit of cycling or scooting, supporting rests between bouts of activity when a child gets tired. There is more work involved. It's more strenuous for a child of smaller stature to run. And so having bouts of rest, but then rejoin that activity is a nice compromise to help participation. The footwear selection, I have some slides in a second to show that. And then tools or assistive devices to be considered. Here I showed some footwear. When we have in-toeing, it can be really useful to choose a shoe that has lower profile, not so chunky, well attached to the foot. So the shoes on the right side are more of a low profile type of shoe, and the ones on the left in the center are less attached to the foot, a little clunkier, a little chunkier, and they tend, when children have in-toeing, they tend to, it can pose yet another barrier to clearing the foot and walking and to tripping and falling and safety sorts of things. So this is another example of coaching to help children progress. I'm going to jump ahead to the slide here. I was referring to typical child toys that are also tools for children with XLH. And in the bottom and the right-hand corner, there are walkers for children who need a little bit more definitive support and is more of a medical device. But all of these can play a role to keep children with XLH active despite knee pain and altered mechanics of the lower extremity. So Tara mentioned participation. We look at the ICF, the World Health Organization's ICF is the International Classification of Functioning. And that classification came out in 2001, and it is an uplifting one in that it doesn't talk about handicap so much as an individual's body structure and function, is at the root of perhaps a functional problem or impairment. It is the job of all of us in the team, the child, his or herself, the family, and the medical team and the therapist to support the body structure and function of that child to help that body improve in terms of bone density in this case, to support activities and that child's ability to take care of himself or to play as a child should, and toward adulthood to participate in the classroom and in the workplace. And those activities lead to participation. That's our holy grail. That's the goal for all of us, to help that child participate. So if it means using an assistive device, or if it means modifying a little bit in order to join those activities and be a part of what we define as the most important elements of human life, is joining our families and joining in our peer groups and activities, then that's where we are sort of take our strategies in terms of intervening. With the kids that were in the morning session too, I had a little fun with showing other assistive devices and things like that that will play a role perhaps over the lifespan in XLH. The girl at the top left resembles several, or a teenager who may have had surgery for torsion or for guided growth, and so is using axillary crutches. A younger child up top with a walker to help support and protect the knees in walking. The bottom left I had a little fun with because he's with a cane and he's smiling and she looks miserable. She's, not doing the right thing for whatever. You got to have some fun sometimes. And then the wheelchair plays a role, particularly post-operatively, but can play a role too if you have bony pain and short stature into adulthood and you are working in a city or working in a large environment. A sport chair could be the way that you get from point A to point B in an efficient way to then walk about your workplace once you arrive. The wheelchair can be a really important tool. I didn't put it in this show, but there is a type of chair also that resembles that one, but has a power assist pack in the wheels. It's a battery pack that gives power assist. That's just, it is what it sounds like. And so if anyone has tried to propel a wheelchair any distance functionally, it is work in itself. And so someone who's on a big college campus or someone who works in the city or has a large office building to get about, these tools are, they're tools. They're tools to help us live our lives and get to the important stuff that we do as young people and adults. Getting to the surgery, I touched on already a few minutes ago, but the most common surgeries, and Dr. Sharkey spoke about it this morning, I believe, the guided growth procedures for bowing when that's persisting, and then osteotomies to address the torsion that is a little less predictable in how it responds to medical management in comparison to the bowing and the growth response. When those surgeries So now I want to talk about the role of PT across that a little bit and reinforce those ideas across the lifespan, older children to young adults. We talked about the role in young children to be more of the coaching model. We get to older children and young adults. The coaching model continues as the bony response is occurring. We're looking for that bowing to reduce, for the growth to improve. The torsion may or may not respond. So some direct treatment may be involved in terms of using devices. The 504 for self-advocacy and for support in the school, as Tara and Julie explained, is a really important tool for your child's one of the natural environments or communities of the school. And then the pre and post-surgical management. When older children and young adults are going through surgery, preoperative management is very valuable, and it's good to ask about this. Is there a way to meet with a therapist prior to a surgery to go through what can I expect after the surgery? What equipment will I need? Plan that rental wheelchair for the first few weeks after surgery when there's some pain involved. Plan that rental walker. Consider the timing of returning to school. Consider the means by which the transportation is going to happen. The legs are out straight. Are you going to fit in your vehicle? That sort of thing. How is that going to work? It can alleviate anxiety tremendously to talk through. That sounds like lots of pragmatics, but that's what it's all about after surgery. All of a sudden you have these challenges that sometimes aren't predicted in the absence of that meeting or that preoperative visit that can iron out some of these kinks and make things smoother after surgery. And then the post-surgical management is what you would expect, that mobilizing after surgery, getting going, and then weaning from support, working on strengthening and flexibility, and weaning from the assistive devices that are needed initially. So to sum up a little bit, we start out the lifespan with patients with medical treatment, watching the movement patterns of a young child progress at their own rate with the mechanics, with the architecture of the skeleton as it is. Patients with that early milestone attainment, balancing large muscle activity, keep that child active and participating, but also balancing that with rest, loading the bones for bone density, respecting the mechanics, preventing falls, tripping and things like that, preventing excessive joint stresses, and using tools to support participation and any questions?
When did 504 begin?
1970s?
70?
74? Or was that 80?
Was
Was that
504.
81?
90,
Okay.
91?
I thought 504 was in 1991.
Because I was really involved when my children were in school fighting for accommodations under IDEA. And,
Right, so that's from the 70s, and that was...
That's the original IDA, right,
So
thank you.
I'm not familiar with 504, and we should post some information on our website for parents with children in school now and who need these services, because this is new information to me, and I've been dealing with this for a long time.
Yeah, it's interesting because in Christine's role in the sort of medical management, so the outpatient specialty clinics, her job is to sort of remind you, and she says, you know, she's going to coach you to be a self-advocate, to get into that school under 504 and try to get some accommodations. And then Julie and I might be on the other end. So when you do advocate, the principal is going to come to us and say, oh my gosh, could you come help this family? Because I just, honestly, I just need to not have them at my door every single day. So then it would be yes.
If we put it on our website, though, everybody can
Right.
go for that information
Definitely.
and share it. So we will
get
work on that.
It's probably the most relevant of the regulations for XLH, definitely.
Thanks. I know we threw a lot at you.
So you guys saw me a little bit this morning as I jumped in because I just couldn't help myself. And so again, my name is Keith Steigbigel. I'm a physical therapist. I primarily deal with the adults and adolescents as well. I co-own a physical therapy practice that's in this region, and I also teach here. So my job, I think, today is just to give you some insight on how we would approach with this. As you know, this is not something that's going to be every third patient walking in through my door. Okay. However, what we do as physical therapists don't really vary too much. Our job is increase someone's range of motion, mobility, check for movement strategy challenges. We are movement dysfunctional specialists. That's what we do. We can watch somebody move and we can figure out why they're moving differently. And then our job is to sort of figure out how we can fix that. With this, there's a little bit of uniqueness because your scenarios, the XLH scenario, is a little bit more unique. And this is sort of an interesting, quick story. One of your peers today approached me, and I saw her as a patient a couple years ago. And so she came up and reintroduced herself and she came in for some hip pain she was referred to me for, and has since had surgery and is rehabbing just recently, and she lives in Massachusetts. Her question was, the rehab she's getting, she's not sure if the therapist truly understands her pathology, not the hip surgery pathology, but her underlying pathology. Because some of the treatment techniques that are going on aren't helping as much as maybe hurting a little bit more so. And I said, you know what, it's very true. This is a unique population. You are an individual in your early 30s. Somebody comes to me with, at that age group, we already have a predisposed scenario of what kind of exercises you're going to need. You don't get those same exercises because of bony changes that start to occur. So you have to understand that with some of the spurring that goes on, where this person being young and they come in with some back pain, typically we'd think it's more discal related based on just history of life. In this case, there may be more bony changes occurring now with the spurring occurring. And so as a physical therapist, when we deal with back pain, typically the first thing we're going to figure out, are you going to be an extension candidate or a flexion candidate? Meaning, are you going to do some extension exercises or flexion exercises? That population typically would get extension exercises. She's been getting some extension mobilization techniques, which she told me is not helping, it's sort of hurting. I told her to please go back and talk to her therapist, have the therapist call me, because what I would probably encourage is more of a flexion program, open the joints up. If the spurring is going on at this point in life, you need to open those segments, not close them. And so you're going to be treated as if you have an older spine than your chronological age shows. So that is where your job is, to educate us when you come into the office. Because as I said, every third of my patients is not you. It's just not going to be that way. And thankfully for that, I'm sure you guys can attest. But we need you guys to let us know. You guys are probably more educated on this subject than most of us here are. You have been doing this your whole lives, and you've been working through many, many organizations, and you know lots about what's going on, including how you feel every day. I tell my students, the best information you can get from a patient is the patient themselves. If you give them 5-10 minutes to talk, they will tell you what's wrong and how to fix them, but you must listen to them. And that's really usually the case. What makes you feel better? I feel better when I sit. All right, so am I going to make you stand up and go backwards 10 times? No, I'm going to bend you. So educate your therapists, educate your practitioners, tell them what makes you feel good and tell them what makes you feel bad, and then tell them a little bit about the pathology if they don't know, and then go from there. Okay? Should I stop there? Slide 1. Okay, so XLH. My job is to treat your pain. I'm not going to be able to change your bone deformities. Oh, that's good. There we go. But my job is to help make the bone deformity symptoms feel less. Okay? I can't change your arthritic changes. I cannot change the structural changes, but I can change your mechanical changes that are around that to make you feel like you're having less of that. Gait changes, the way you walk, the way your mechanics are being set up, how we can play around with those a little bit. Postural changes, how you sit throughout the day. You know, the longer you sit, the worse you feel. The longer you sit better, the better you will feel than the opposite. And your quality of life, okay? Pain treatment. We have a lot of different tools in our toolbox, or our tool belts, as we like to call it as physical therapists. Modalities. Again, this is not going to change your pathology, but it's going to make you feel better so that we can do more activities later. Heat, ice, anti-inflammatory techniques. That's what ice is. It's a natural anti-inflammatory. Heat increases blood flow to the muscle tissue, allows you to move a little bit better, gets the fluid around the tissue, around the joints themselves to move better. TENS units. Have you guys had experience with 10 units, electrostimulation 10 units? The little box things that look like this. Okay. These are nice sometimes because they actually block the pain sensation to allow you to move better. And they're portable. If you're having one of those tough days, they can be worn throughout the day. They can be tucked in your pocket. You can turn it on and turn it off at will as needed. And they actually can help promote more movement because you're having less pain. Iontophoresis. I'll talk about ultrasound in a second. Iontophoresis. Have anybody had any iontophoresis before? Okay. It's not a scary thing like taking blood out. When I say iontophoresis, I think we're phoresing them. It's this very neat little other box that we are able to actually inject medicine with without a needle. So there's no source of infection, there's no pain involved, it's a tingling sensation, and depending on what the medication you use, you'll have different outcomes. Dexamethasone is the most commonly used medicated, it's a topical treatment, okay? So that particular medicine is impregnated into a pad, the pad's put over an area that hurts, and the machine then pushes it in. It works on phoresis, which is every medicine has an ion polarity, okay? So when you break down that medicine's ion polarity, it's either going to be a positive or a negative ion polarity. Like two like magnets, north poles will bounce off each other. We take if this particular medicine, dexamethasone, which it does, has a negative polarity, we will hook up a negative charge to it, and that will drive that medicine into your tissue. This works very well on superficial tissues and structures. This is not going to be great for a deep capsule of the knee joint, but it will be good for a spurring or a pain around the end plates, shoulders, ankles, elbows, sometimes your outside hip, that kind of stuff. Dexamethasone is a steroid, so it's good for inflammatory problems. The acetic acid has been, I've seen some studies where this actually can help with some change of spurring specifically because of the way it reacts with the calcium carbonate molecules, and it'll actually help soften the spur to help it to be reabsorbed. It might be an interesting thing to study with this population, especially with spurring being such a high prevalence. So that's your iontophoresis. Ultrasound. Also, there's been some studies where we've used it with calcific tendinitis of the shoulder. Again, so if you have calcium deposits within tendon tissue, this has been shown with some studies that over a period of time of treatment, it can actually soften, again, help reabsorb some of the calcium deposit within the tissue. Okay, so ultrasound, iontophoresis, two tool belts we can use. Again, these are going to be used more over your local areas, but if you're coming in and you're having a flare-up of a shoulder problem that is specifically linked to this, and we get more mobility, that helps you move here, which now maybe gets you back on to doing other things like activity and exercise, which can help with quality of life. All right. Lots of stuff here, so raise your hand if you have questions about any of this as I move through this, okay? Stretching. When I first started, when I was asked to do this, I started thinking about this population, and the first thing that came to my mind was the ankylosing spondylitis population. I don't know if you're familiar with this, where it's the bamboo spine, where there's a lot of spurring that happens within the spine itself, and the patient becomes fused, basically. And the biggest thing we've done with that population is to keep them moving. From the way I see it, this population, the XLH population, isn't much different. If we keep the XLH person moving, then it does allow the body to become more and more stiff. And that's why exercise and stretching is so important. So stretching, I would want to make part of your daily process. Brush your teeth, stretch. Put on your shoes, we stretch. So it's got to be part of everyday stuff, not did I remember to do that. It's got to be an automatic part, okay? And that takes a little bit of work. Isometric controlled progressive resistive exercises. Again, this population we have to think about a little bit, because we know that bone grows and becomes stronger with resistive exercises. Your osteoporotic patients, we will increase resistance to increase bone strength. But if your bone is also very weak, we have to be careful on how much resistance we include in the very beginning. So isometric strengthening is a nice way to start. That's just against a fixed position where we're pushing against something, against just using your own body strength without a lot of resistance back, and you can apply as much force as you need to. But again, you're creating a contraction around the joint. You can make it as simple as one hand or a whole body. Okay, either way, you're getting resistance back from what you're pushing into. Progressive resisted is when we start dealing with bands and movements and things that do give us some resistance back. Okay, posture re-ed. Re-educating you on the way you sit and stand and walk, to me, is huge, because those forces, those axial compression forces of gravity coming down on your body on an everyday basis will make a change in how your body is feeling and how the joint tissue is absorbing those forces, and then how you respond to that, especially pain-wise. Orthotics, AFOs. We've talked about the legs a lot today with the bowing. From a surgical standpoint, obviously, you guys are well aware of the osteotomies of taking the bowing legs and making these pie cut shape changes to try to make some straightening. There's also orthotics, a very simple tool we can put into the shoes, where when you use the orthotics, you can also use wedging. Okay. Now, so this is not going to be used in some of your extreme cases, but it may be used post-surgically, or in some of your more mild cases, or it might take an extreme case and take the edge off a little bit. Where if we have a bowing, in this case, and this is your concave side, this is your convex side, over time you will see your concave side becoming more narrow and more compressed. Okay, similar to the arthritic knee, the osteoarthritic knee of medial joint line wear and tear. In the beginning, in our children, we don't see so much of this because of the pliability of the joint tissue. But if we create and we put a lateral wedge into your orthotic, normal physics say as you step down and the forces hit here, it's going to then take the next joint up, which is the knee, and drive it more in, decreasing some of that concavity, elevating, opening up a little bit of the medial joint line, again, taking off a little bit of the stress, which am I changing your leg? No. Am I changing the symptoms? Possibly, which makes, again, you walking down the street feel better and maybe getting back into that exercise program that we barked at you try to do, but you said your knees hurt so you can't do it, and now your knees hurt a little bit less, so now you can. Okay, so it all comes back to the beginning again. Some severe cases, AFOs are used. Again, as you increase your stability of a device, you get a little bit more of a dramatic change. More devices sometimes also have more resistance, and so you have to do what you can based on what you have. Okay. Questions on that? Yeah.
Yeah, the AFO, is that shaped like do they mold that like an orthotic to the bottom of your foot as well, so you get both?
AFOs are very neat. They are exactly that. They are molded to you. An orthotist will be in charge of doing this very often with the PT there, because you can make these things do a variety of things. You can limit range of motion, you can increase range of motion, you can help facilitate movement patterns, you can decrease movement patterns. So this can be as big and bulky or as streamlined as you need based on the function. So those come in different shapes and sizes, and they cover different levels of joints. They can cover just the ankle, they can go above the knee, they can go up to the hip based on what you're looking for. All right. With that, you have offloading braces. Braces that are made to specifically take that bowing, okay, that varus knee joint, and then as the brace is applied, it creates a force here and here going this way and a force going that way, which then helps realign the joint. Okay, so with weight-bearing patterns, you have less strain through that joint, as Christine was talking about earlier, how that can affect the body. Your normal joints, what we call normal, versus your varus or your valgus knee joint. Posture changes. As my daughter shows, she has excellent posture while on the beach or waiting for the seals. How you sit is going to change in how your forces is felt throughout the body. We can sit in what feels comfortable, and if you stay in that position too long, that comfort actually might feel worse later on. Sitting in general typically will feel worse later on. So with this population, cross-legged sitting is typically something we look to not do. Abnormal sitting postures, lying postures, we try to change or educate to decrease forces on your particular setup. Not every person walking into the room will be the same. Not everyone will have the same deformities, the same level of deformities. So everyone might need a little bit of a different postural re-education program based on what your needs are. Your simple lumbar roll, as simple as that looks here, can actually change everything all the way up here. The best thing I like to do in my office is I have one of those stools that go up and down. Not that I like to play with the stool, but that's partly true. But as you slump down into the chair, you can see my neck. As I elevate the chair, by just changing here, what it does to my head and neck through here. So by improving your lumbar lordotic or lordosis, you can improve your cervical lordosis. So a simple change can make a dramatic improvement. I always tell people in your chairs, if you can, elevate them just high enough so if you have a marble in your hip growing region, it will roll down. If that marble stays there, you're sitting too deep, because the deeper you sit, the more you're going to be forced flex forward. Okay? Manual mobilization, probably a little too aggressive here. But it's something that your physical therapist can do. Okay? One of the things that we like to do is we like to poke and push and beat you up a little bit. But it's all with love, of course. It's just to make your joints move better, you get your range of motion back, the stiffness you have in certain areas, the hips, the shoulders, the knees, you're coming in, they just don't want to move all the way. The range of motion's there, but they haven't been there for a while, and so they need to be just given a little extra push, okay? They might look like this, a little bit more appropriate on the shoulder, and then some knee. Sometimes you'll have a belt involved to help distract the joint. In this case is another perfect example of how your population might differ from another. Because of the bony spurring formation around the joint, I would want to add a little distraction to that joint with my mobilizations. Pull that joint away from the capsule where the spurs may be lying to allow some freedom of movement to encourage tissue movement without running into the spurs. Okay? So those little tweaks can make a big difference in how the joint mobilization will feel, just pushing versus a distraction with the push. Does that make sense? All right, are you balanced? I don't think anyone is fully balanced. I know I'm not on most days. But the chain effect is what we're talking about here. If one thing's off, the rest will be off. The better we can help make changes in one spot, the rest of the system will feel better. It's amazing how everyone starts to move and sit up in their chairs as I do this part. Okay, stretching. Okay, this is my other daughter. She's very flexible. Okay. So again, this is not something I would encourage my XLH patient to be doing on the beach. But again, stretching, as we talked about, alleviates the strain of the tendon on its attachment points. The less tissue tension you have at its attachment point, the less pressure and pain you're going to have where it sits, and the greater range of motion you'll have as moving without a tug at the end of that movement. Okay. Spinal stenosis, I'm sure you guys have heard this thrown around. This is unfortunately a common condition that we start to see develop over time. And again, with that, we start to implement more of a flexion program versus your extension program. Do you have a question? No? Okay. So again, that's where this population is going to see a little bit of different change in a treatment than your everyday population. Okay. Flexion techniques. The Williams flexion program, a very generic flexion program. A great thing to open up the spine, to have people do and give them this knowledge of just leaning forward, grabbing the ankles and pulling themselves gently forward to get that stretch throughout the lumbar spine. It can be done anywhere, in the park, in the house, when you're out and about. Typically, my biggest complaint is I can make from here to there, but once I go beyond there, I have pain. Okay, well, between here and there, if there's a spot you can stop, get into this position and stretch, you might be able to get from there to here with less pain. 5 to 10 times, usually a few seconds in between. Again, the more we do this, the more we open things up, the easier it is for them to keep moving. Okay, some single knee to chest stretches, very simple exercises you can do. The spurring, I always think of the ankle spurs, but in general, stretching the gastrocnemius, the gastroc, the muscle in the back of your calf, and then with a knee straight, with the knee bent, you're going to get more of a stretch around the Achilles. Again, this will allow for better mobility because there's less restriction on the end point of your gait cycle. Okay. As we move less, we take shorter steps. As we take shorter steps, the muscle tissue becomes tighter and we don't want to move more because it hurts. As we increase the length of tissues that allow us to move, which is specifically the posterior chain, which we call the hamstring and the gastroc and all this stuff in the back end of the body, which is what we need to move forward through movement, the better you're going to feel. Okay, this is part of every day brushing our teeth, we stretch. Hamstrings and hips, again, with a belt. It could be a towel. It could be something fancy like this thing. It could be a bathroom towel or a beach towel as well. Doesn't matter, but having that strap makes a big difference on how you get to your foot. Okay, if you're struggling just to get to your foot, you're not going to do it tomorrow because it was a struggle. If you have a towel or a strap and it made it a little bit easier, then you maybe pick up that towel or strap again the next day. Getting it outside of your hip, this region where all those muscles attach, take that same towel and just stretch up and over your body to your tolerance. More is not necessarily better here. We edge the pain, we do not push through the pain. That's key. When we push through the pain, it's called job security for me because you're in my office more. Okay? I just need you to go to the edge of pain, which allows the tissue to be stretched. Does that make sense? Stabilization. We have to stabilize these joints that we're making loose. Some simple stabilization exercises are just stabilizing the lower spine. Again, the posterior pelvic tilt has been done for years. This has multiple variations based on what your needs are. But again, it's just using the abdominal muscles in a slightly isometric way of lying on your back, pulling in, and creating abdominal support, which helps with sitting. As we get fancier, we can go on some more quadruped exercises, sticking that leg out, and we just got done stretching it, and now we're stabilizing it by making it hang out there, and those muscles have to contract to hold it there. As we get really fancy, we add a little more lever arm out front, which now we have to use this core to help stabilize as we become a little bit more unbalanced. Okay. The PREs, the progressive resistive exercises, the rubber bands, you've probably all seen at some point in your therapist's office. Doesn't have to be anything fancy. Okay, it could be around a door handle, or it could just be in your hands and just puffing the chest and squeezing the shoulders. To me, this is one of the more important ones because all day long we're like this. If we sit behind a desk, we're like this. Computer, we're like this. We're reaching like this. This very rarely gets this. So if you have one of these, great. If you don't, I'll tell people just throughout the day, give me this. Your hands by your sides. Roll open, get that chest open, and squeeze the shoulder blades together. We're reopening the chest, stabilizing the back, which again allows us to sit up taller. And as we sit up taller, it's easier for us to have better posture. It also sets us up for better ambulation. Okay, but it's a very simple exercise we can do throughout the day, just breaking up our daily habits of sitting there too long in one spot. Okay, other activities, swimming. If you have access to a pool, fantastic. Walking in the water, swimming in the water. Yoga, there's so many variations of yoga. It doesn't have to be standing on your head with your foot behind your opposite ear. There is chair yoga. There is simple yoga. There is hard yoga. It's just finding the yoga that works for you, which is just another way of stretching joint tissue throughout the day. Walk to your level of tolerance. As we walk, it's weight bearing. Okay, weight bearing activities are what help our bodies stabilize. It's Wolff's Law. As the astronauts go into space, gravity is eliminated, they lose bone density. Okay, gravity is what creates our bone density to keep reoccurring. So we need to have that resistance. So anything weight bearing is going to help the bone tissue continue to recreate more good bone tissue. So eliminating that from your diet is not a good idea, because we need that, especially in this case, to help keep bone growth in the right direction. Recumbent bikes, another way to exercise if you're having a hard time ambulating. Dancing, could be in your kitchen, could be in your bathroom, could be out and line dancing, but a great way of moving. And that's the bottom line, is keep moving. Okay, any questions? How to get services, I think everyone prior to me has done a fantastic job about that. Talking to your doctor, talk to your community. That's your best resource. Where you went for services, did it help? Did it not? Was it great? Was it not? Whatever. Talk amongst yourselves is where you're going to get some of the best information you can get. Yes, physical therapy is covered. Yes, it's a pain in the butt. Insurance is insurance. That sometimes is what we have to do together and work on how we can increase your access to us. And that's where sometimes you're not coming in as an XLH patient, you're coming in with someone with a knee problem. And then next week it's a back problem. So your pathologies become your gateway to having more services. If we come in just with someone with XLH, well, the insurance company knows this is not going away, and it's very difficult to extend your care. So we need to sometimes attack this from each symptom versus the main pathology from a physical therapy standpoint. Okay? Questions? I have my little tools and things up front if you want to look at later. But otherwise, I'll pass this on to the occupational therapy department.
So we're going to move on to occupational therapy now, and some of this I will go through quickly because some of this was covered by Tara this morning in terms of what is occupational therapy. But again, looking at the adult population, I work with the adult population. I've been practicing for 27 years now, and I've worked in a variety of settings for all adult from the beginning of my practice. So if we look at what does an occupational therapy do, and Tara said earlier, occupations are the tasks. They're what you do every day. And I try to convince people occupation is your activities. What are your tasks that you do in a regular day? And obviously you need these tasks for quality of life. So the three general questions I ask every client before we start even looking at how much range of motion do you have and all of those types of things is, what do you want to do? What's a typical day for you? And what activities do you want to do that you can no longer do? Because maybe we can come up with a different way for you to do them. And what's important to you? So I have a client right now who likes to ride horseback, and I said to her, okay, now what else do you do in a typical day? Do you want to get back to doing laundry? No, my husband's doing that. Do you want to get back to mucking the stalls with the horses? No, my husband's taking care of that. And there are a lot of things that she did for a long time that now she said, I really don't want to do those things. If I don't have to go back to them, I don't want to. And she's not the first person to say that to me. There's plenty of people who have said to me, I've even had people say, I don't care if I can dress myself, I want to golf. That's really what's important to me. And I'd say to them, well, why is that so important? And they'd say, and one woman in particular said to me, I've been taking care of them my whole life. It's their turn to take care of me for a little while. So everybody's different on what's important to them, and that's really what we look at within occupational therapy is what has importance to you, what do you want to get back to? And very quickly, adult settings cover the gamut. You heard about all the pediatric settings earlier. And quite honestly, I've worked in every one of these at one point in my career. And so the acute care hospital, obviously you're in, you're out. It's very short term. Oftentimes from there, many people will end up going to a subacute, which could be in a nursing home setting. They may have a subacute floor. It could be a place like Gaylord or Montouise here in North Haven that's only subacute. And then people will shift over to home care once they're done with the subacute care. Then oftentimes from there, they come to me at outpatient. So they have been seen quite a bit before they typically get to me in the outpatient setting. Then there are people who are in adult daycare centers, long-term care, and we also work in mental health. So all of those, we cover the gamut in terms of where we might be. We call them areas of occupation. So looking at your basic skills. Can you feed yourself, dress yourself? Can you brush your teeth? Can you blow dry your hair? As we heard Tara saying earlier, it was difficult for her now with her broken arm. We also look at the complex tasks that you do in a typical day. Driving is a big ticket item for a lot of people. They want to maintain that independence through driving. Can they do their grocery shopping? Can they pay their bills? Can they take care of their house if that has importance to them? So those are more the complex tasks that we look at. We also look at work. Can you return to work? If so, do you need accommodations? So that 504, which they were talking about before for children, is called the American with Disabilities Act for adults, and that does provide accommodations within the work setting. We also look at leisure. 504 does play, or ADA does play a role in leisure. You have to be able to get into the movie theater and all of those types of things. But also for this woman who wanted to get back to horseback riding, how can we get her there? So we had to adapt how she got onto the horse, and she was left-handed and had a stroke. So we had to adapt how she rides that horse now. It's a different way than she did before, but we got her there. So looking at leisure to us is just as important as work and housework. You have to have that balance. And then social participation, which Ro is going to talk a bit more about in terms of interactions. So we look at three basic areas. We look at the person. What skills do they have? And I think that's important when we cover, I'll talk about payment in a minute, because we said we don't look at diagnosis as much as we used to, because quite honestly, even for all diagnoses, the insurance companies are saying you're not fixing the stroke, you're not fixing the head injury, you're working on the effects of that. So when we say that we don't necessarily get coverage for you as with your diagnosis of XLH, that's really true for most people, that we get coverage for what can we do for them, what functional skills don't they have that we want to get back for them, not necessarily the actual diagnosis. So we look at the person. What skills do they have? We look at the task. How can we adapt that task? Or how can we adapt the environment to make them successful? So purpose of the individual, the task, as well as the environment are the three areas that we're going to be looking at. Part of this is looking again, asking what do they have to do and what do they want to do. She may not want to do grocery shopping, but if she lives alone, then she has to do grocery shopping. She may not want to do the housework, but again, people who live alone, and when I work with many of my clients are elderly, and many of them do live alone. So there's tasks that they want to return to, and I look very carefully at those, but we also problem solve, okay, you have to be able to do these certain skills to function, to stay independent in your own home, and that's really a big push now, is for people to stay aging in place and staying in your home as long as possible. So we do a lot of adaptation in OT. And these are just some examples, and I actually brought some things later on that I can spread out on the table if people want to come up and look at things. So and this Patterson Medical is actually one of the bigger suppliers. They've bought out all the other suppliers. So looking at some of these things here on the bottom is some built-up handles. So if you have trouble holding onto something, you can build up the handle. Adapting shoes for individuals who can't tie their shoes, children or adults. Again, on the far end there is more adaptations. There's a key holder. There's a zipper pull on the upper right-hand corner. If you can't reach all the way back to get that, there's a string on there that you then just tuck into your shirt after you're done using it. And a jar opener, and I actually have this at my home. And I think it's important that we understand you can go to Patterson Medical, and there is a piece of adaptive equipment for anything you can think of. Somebody has invented a piece of adaptive equipment. But it's also important to look what's mainstreamed. What do I have in my house? I have a one-handed can opener just because it works really well. I use a built-up, I have some pain in my hands from overuse over the years. And so I look, when I go shopping, when I'm looking for a toothbrush, I look for the biggest possible toothbrush I can find instead of a small toothbrush that I really have to grip tightly. So there's a lot more that's becoming mainstreamed, and we can thank the baby boomers for that, because as they have aged, there's now a market out there for all of this adaptive equipment that used to be kind of reserved for the therapist, and now it's much more popular mainstream. So there is a lot that's available. I think cost is an important consideration when you're looking at these things. Adaptive equipment is generally not covered by any insurance company. And they typically run you can get elastic shoelaces that you change your sneakers from tie to elastic, and they now become slip-on shoes. And those are $3. So you can get something inexpensive. Adaptive equipment can get very expensive. Most of it stays in the $30 to $40 range. Some goes a little higher, some a little lower. And as I mentioned, there are many more products that are mainstream today. And because typically you don't want to get it from a hospital-based provider. If they're going to add a markup, you want to go and get it on your own if you can do that. Then we have something called durable medical equipment, and that's different. Your durable medical equipment are your big ticket items. Is your hospital bed, your walker, your wheelchair. And this generally is covered, but not always. And we'll talk about if any of the durable medical equipment is to be used in the bathroom, it's typically not covered. And that's kind of the way that they've decided to cover items. So if you need a tub seat for your shower to make it more comfortable to sit down and shower, that's not going to be covered. I had a picture of a bedside commode up there. If the bedside commode, if your therapist can justify that that needs to be used at night in your bedroom, then that will be paid for. So then what we tell people to do is, okay, get somebody during the day to then take it and put it over your toilet in your bathroom, because they're paying for it to be used in the bedside, but during the day it can serve a different purpose. So unfortunately, once you hit the bathroom door, most equipment is not covered. But the hospital beds, the walkers, the wheelchairs, those types of things will be covered, and there are restrictions on all of that. And there's actually a new system put out by Medicare. So if anyone's trying to get payment through the Medicare system, they now have a bidding process with Medicare for vendors that they unfortunately weren't real good at advertising to people, and people are unaware, and suddenly they were getting their diabetic supplies, and now they've been told it won't be covered. Well, it's not that the diabetic supplies won't be covered, it's that you're using a vendor that's no longer acceptable. So if you're working through the Medicare system, then you need to go through there. You need to go to medicare.gov and go through their system and find a vendor. So part of that is relying on the therapist to help you. If I'm recommending something, I'm going to help that client to figure out who is the proper vendor for that. So again, advocate for yourself. And if somebody says you need this piece of equipment, don't just say, okay, say, can you help me figure out how I get that piece of equipment? Can you give me some suggestions? And most therapists should do that for you. And then Medicaid will vary by state. In the state of Connecticut, Medicaid covers durable medical equipment, including the bathroom. So an individual who's on Medicaid in Connecticut can get the shower bench and the grab bars and those types of things covered in the bathroom. So that will vary by state. So again, we're looking at we're looking at changing the task. Now we're looking at the environment. How can we change that? So adding safety. Grab bars are a good example of that. And again, you can go to Home Depot and buy grab bars these days. You don't have to get them through a medical supply house. Increasing ease. So just walking through the kitchen and saying, okay, what do you use the most? I use this, and many of my elderly live alone, so they say, well, I use one plate and I use one glass and one knife and fork. Well, then why are they on the top shelf? Let's bring them down, let's put them where you can easily reach them, and arranging the home in a way that they can get to all the items that they want quickly and easily. And again, that decreases them climbing up on a step ladder or climbing up on something if it's up too high. And then increasing endurance. So looking at the environment and saying, okay, you love to cook pasta every Sunday. Can we put a little step stool there so that, or a little seat rather, so that you can sit while you're stirring the pasta? Can you sit at the kitchen table and cut up all the ingredients? I know that's not what you're used to, But if you can sit at the kitchen table and cut your ingredients, then you won't be quite so tired by the time you get up to actually go and cook the sauce for the day. So looking at what are the tasks they're doing and looking at their environment and seeing if we can cut down on the amount of activity that they're doing, if appropriate for that client. A lot of the interventions for pain management are a lot of what Keith just talked about. We have all those same tools in our toolbox. Ultrasound, paraffin, heat, cold, antiphoresis, all of those same things are available through OT. And then the joint protection principles. And basically the principles are that we use the larger joints. So instead of carrying your laundry basket like this, I have my clients carry their laundry basket this way. So they're not using their finger joints anymore, they're using their elbow joints to hold that up. A lot of them like to carry their pocketbook this way, and I try and get them to put it on their shoulder. So for you, looking at which joints are bothering me and how can I adapt the task so that I'm not putting as much stress on those joints as we go through the activities with you. I always have people that come in and they think it's really good to squeeze a tennis ball, particularly people with arthritis and injuries in their hands. And we want to really talk about what's the balance. And Keith talked a little bit about that. Yes, we want to exercise, but we have to balance that with we don't want to be squeezing a hard tennis ball because that's putting a lot of stress on those joints as you're squeezing that. So we want to be really careful about doing a really long static, squeezing something hard like that, or getting one of those hand grippers. A lot of people think they should go get those. And we have to really balance out, yes, we want to stretch, we want to keep moving, we want to strengthen, but we have to balance that with not overstressing the joints. And so that's one of the things we'll work with you on figuring out what activities are really stressing me and my joints and what activities I'm more comfortable doing. And that goes into our maintenance programs. And maintenance was always a dirty word in therapy because as soon as an insurance company saw maintenance, they didn't cover that. But with the Affordable Care Act, we're starting to see more prevention. And maintenance is just that. Maintenance is prevention. So again, we have to play the game a little bit, and we don't call it maintenance, we call it prevention. And then we're more likely to get it covered for people who need regular exercise. I have clients who come in on a regular basis with Parkinson's, with MS, with other long-term diagnoses, and they see a little bit of a decline, they come in, we're able to work with them, maybe change some tasks around, redo their exercise program for where they are now, and then we don't see them for a while, and then they might come back in. And I have lots of people that do that on a regular basis, and it does get covered. They're not paying privately for that. Now, the client who wants to come on a regular basis, ongoing, wants to see therapy, either PT or OT, once a week, forever, yes, they're going to have to pay out of pocket. Insurance is not going to cover that. But for people to come in every once in a while and be seen and update their rehab program, is typically covered by most insurance companies. I think it's really important to understand that your diagnosis is nowhere near the same as the person next to you. And oftentimes I hear that, I treat a lot of folks that have had stroke, and they look around and they say, how long has he had his stroke? And when did he have his? Because they're trying to compare themselves to, will I ever get better? You know, if he's been here for 3 years and that's all he can do, or if he's had a stroke 3 years ago and that's all he can do, there's no hope for me. And it's really important to understand that with all diagnoses, there's a gamut of symptoms. And we look at the individual, what are your symptoms, and what are the issues you want to work on. I have a client now who's had a stroke 3 years ago, and yes, he's still coming, and yes, he's paying privately because he comes twice a month now. All he wants to do, old school gentleman, owned his own corporation. He wanted to be able to shake hands. That was a big deal to him. And he is so excited now that he came in with absolutely no function in his arm. Now he can lift that arm and he shakes everyone's hand. Before, after therapy, he's shaking your hand. And to him, that held a great deal of meaning. To me, it wouldn't be as important. He used to shake hands with everybody this way with the other hand, but that, of course, was not how he was brought up and his background. So that meant a lot to him. Other people, they're going to have different goals, and he paid privately to get to the point to shake hands. And he works every day at it at home as well. So I think it's really important to understand we treat you as an individual. No matter what your diagnosis, It's looking at what are your skills, what do you want to do, what do you have to do. Very briefly, looking at coverage for OT, I know that's always a concern for people. Obviously, you can pay out of pocket. It is expensive, and most people can't afford to do that. Medicare, Part A covers your hospital. Part B covers your home care, your outpatient, all the other settings. And none of this is 100%. People come in with pretty hefty copays these days. And so the copay could be $30, $40, and if you're coming twice a week, that could be a lot of money. So some people do have secondary insurances to cover the other half. Medicaid is, if it's your primary insurance, again, I think very early on, Dennis said part of what they struggle with is trying to get people coverage. Not everyone takes Medicaid. So you have to shop around and see who will take it if it's your primary. If it's your secondary insurance, you're more likely to find someone who will take it, take your primary and take Medicaid as your secondary. Private insurances typically will give you a set number. So they'll say you get 30 treatments of OT a year, or they might say 30 treatments of OT per diagnosis, and that's more of an issue. We like when it says per year. Some insurance companies, at outpatient in particular, I have insurance companies that will only let you come for one type of therapy. So if you want PT and OT, that's fine. They'll pay for both, but not on the same day. So they're playing the game because they figure that you're not going to be willing to come to therapy every day. So you're only going to do baby PT once a week and OT once a week instead of coming twice a week for both. Other insurance companies will let you come on the same day for both PT and OT. So it really matters what insurance you have, and wherever you go for therapy, they should be able to look that up and tell you that information. Then we have the Patient Protection Affordable Care Act. So we now have health insurance exchanges. So if you didn't have insurance before, you're now mandated to get insurance. And the state of Connecticut, the health insurance mandate says 30 OT visits a year. Which actually is pretty good considering these are people who never had insurance before. So 30 visits doesn't go very far, but at least it's something. So it's a start. So whatever state you're in, you'd have to look, if you are now mandated to get insurance, you'd have to look and see what the coverage is because it's all over the map in terms of what's covered for OT. Any questions? Yes?
Catherine, our society in general, in my opinion, seems to be turning more and more towards the practice of bullying, which I think not only occurs in children, but I think also in adults who aren't normal. Does that fall within the occupational therapist realm, or is that outside of your field?
Well, I guess it would depend on what situation it was occurring in. Ro's going to talk about social participation, but certainly looking at what do we consider, quote, normal? There are a lot of people with disabilities who would say, this is normal. You know, you have red hair, I have brown hair. I have no hearing, someone else has no vision. And that is normal, and that we shouldn't be trying to fix that individual. And so there seems to be a push towards, this is your normal, whatever you have. So we're not trying to fix you. We're just saying what's important to you and what do you want to work on to get to what's important to you. And obviously we can't get you there every time. I had one client who was a concert pianist and had a stroke. I couldn't get him back to being a concert pianist. That just, his recovery was just not there. And I actually had another one who was a world famous opera singer. And no matter how many times the speech therapist worked with him, she couldn't get him back. And I thought he sounded beautifully, but he said, no, I'm not where I used to be. So we're not always 100% successful, but we're trying to get people to have quality of life. And so looking at what's quality for me, I think is really important because they are concerned. I have clients who won't use a walker because they say, oh, I don't want to look like I have a disability. And so we do talk to them about that and about the fact that this is your normal. This is okay to be that way. And if you're going to not use that walker, you're going to fall. And that will have greater consequences than not using the walker. Did that answer your question? Okay. Any other questions? After row is done, I actually have some adaptive equipment here if people want to take a look at stuff. I have some things here as well. And at some point, if anyone's interested, you can always come back or contact one of us, or we can go today. It is a bit of a hike from here, but we do have a model apartment that is adapted with some higher end things like a stove that goes up and down, and a sink that goes up and down, and a cabinet that goes up and down. So, you know, if somebody and a lot of that is getting normalized. It's something called universal design. When we built our house, my husband is 6'4" and I'm 5 feet tall. So you can imagine nothing in our house matches up. So everything in our house is adaptable. In the kitchen, we have different heights. We have some that's shorter, some that's higher. Above the dishwasher is raised. And we have that in our model apartment as well. We raise the dishwasher because a lot of people have back injuries. But even for me, even though I'm short, I still like having the raised dishwasher. It still makes my life easier. So a lot of these principles of universal design, of making things fit for everyone, are certainly out there on the market. Now, they all come with costs. There's no doubt about that. But if you're building a new home, it might be worth contacting an occupational or physical therapist. There are actually people who are certified in aging in place. They're called CAPS, Certified Aging in Place Specialists. But even if you have the opportunity to adapt your home, maybe do something smaller, looking at, if I need a new refrigerator, where are the buttons on the refrigerator? Where are the stoves? What's the lighting on that? Or if I need a new stove, where are the buttons on that? So universal design would help a lot with that as well.
Where is that apartment?
It's in the other building on the 3rd floor. So if anyone wants to go after this, I'm happy to take people over and show people. It just is a little, we have to go up to the 3rd floor and walk a little bit. All right.
As you're hearing, I'm going to talk more about the psychosocial aspects of coping and what some of those phases of adaptation look like. Can you hear me all? Okay. And the gentleman who asked about bullying, that's a beautiful segue because part of my topic is looking at the impact of stigma, among others. So I have a lot to learn from you as well. So I would love to invite you to participate and share maybe some of your stories, if I may. Maybe that'll keep us all awake. Right now, I'm actually a little chilled. How are you doing? Everybody's okay?
You're staying at the podium, you can use this.
Sure.
If you decide to.
I tend not to stay still. Okay, let's see. So you let me know if you can't hear me well. Okay. So just a little bit of a background of how I got interested in this. I became an occupational therapist because I wanted to practice in mental health. That's a little unusual. However, the origins of mental health, the origins of occupational therapy are in mental health. So in the early 1900s, occupation therapy emerged within a mental health setting under Dr. Adolf Meyer, who at that time looked at mental illness from a biological, a psychological, and a social view, and hired the first occupation therapist, who was really a social worker at the time, but then got labeled and got hired as an occupation therapist. I often wonder if we remained occupation therapists, would that be a little bit easier? Because as Katie and others have said, a lot of people think that we're going to help them find a job, or we're occupational health. And in fact, what we are the experts in the occupations of life. And so we are involved on many levels. When persons have disruptions in occupations, an occupational therapist can help to understand and restore, adapt, compensate for some of those disruptions as you're hearing. So that's how I got into this, and that was 1980, and I worked in the very beginning with persons who had chronic mental illness that were coming out of Fairfield Hills Hospital. Do any of you remember Fairfield Hills Hospital in the days? Shut down now, as many hospitals have been closed up. And these were persons that had been institutionalized 30 and 40 years and were reintegrating into the community. So I started in a community-based center, and part of my role as the activities coordinator was to help people to make that adjustment to being part of social society and social integration. It was incredibly difficult. as you could imagine. And some had a resiliency about them, and others, all they had to do was come off their medication and they got themselves readmitted. So it was a really interesting start for me. In 1984, I started teaching here, and by about 1990, I'm an old timer, I've been teaching over 30 years actually, and the PT department approached me and said, we need a class, it's been part of our accreditation recommendation, a class on psychosocial aspects of physical disability for our PTs. So at that time, I designed a class with a PT, and we started to teach this very title right here. So at that point, I was not a marriage and family therapist yet. I had been working as an OT, excuse me, as I said, and very interested in all the psychosocial aspects. And I found this body of literature and knowledge, and it has continued to grow since then. So there is a course here that the PTs take, and of course it's in the OT program as well. So the first thing I want to say is it's a given, right? You could probably tell me your psychological and your social reactions are a given. And I don't know if anybody here has had an experience of being told, don't worry about that, or don't fret so much about that, or just get over it. Has anybody sort of had their feelings minimized along the way? Maybe not intentionally. Would you like to say a little bit more about that?
Share a little bit about anything specific, but, throughout life, every now and then. Don't worry about that, just get the job done. Or
Keep on trucking?
Yeah.
Okay. And how did you feel at the time?
Lesson.
Yes. Yeah. Well said. And I do think, thank you so much, I do think that a lot of people don't realize that it may be trying to give you a piece of advice and trying to empower you, but in fact, it has the opposite effect of making us feel diminished and feeling like, gee, maybe that wasn't so important. It's not validating by any means. So in occupational therapy, going back to the gentleman's question, psychosocial is a given in any of the settings that we work in. So if an occupational therapist is in your life because of your children or at any point along the continuum of care, I would hope that an occupational therapist would be sensitive enough to not say that to you and to not say, don't worry about it. Tell me more and help me to understand to what degree that is affecting you. And then social participation, of course, is very important for all of us because we're human beings. So to not have a social connection, sure, we could have a virtual connection. Now we can use computers, but that's not the same. So if it's something that's preventing us from experiencing life, it is very important. So you can tell me, I'm sure, that this is a given. At different points in your life, I am sure that you've had different emotions going on. What adjustment is defined as is your best state of mind. So the optimal state that you can reach, that's the adjustment. So adjustment is looked at as the outcome goal. So how do we get there? OTs have a mantra. We are adaptive and flexible. OTs, as we approach our work, have to think outside the box and be very creative and innovative with that. The truth is that the more adaptive we are in life, the more happy or at an optimum state of being we can be. So what if we're not equipped to be as adaptive? Are there people out there who can guide us and help us and show us the way? I would like to think so. And what is critical is not only that you have rehab professionals, your loved ones, your family, your social support system. In many of these studies, the social supports are a critical, significant variable in your adjustment. So if you have persons that you could rely on who are there for you and support you, that is so important in and of itself. They can be the best listeners. They don't have to try to fix your problems. It's not about advice. It's about you feeling that sense of support. Does that make some sense for persons here? Have you come to recognize the significance of having support along the way? And are you finding that in practitioners as well as your family members? Anyone give an example of that? Hi.
I did talk therapy for a few years where I'd come in once a month, and she helped me cope with the decision to file for disability and the whole redefining myself. And like you said, basically just listen, and they would tell me I was crazy when I said, when I started obsessing in the wrong direction. We clicked really well, so she could tell me I was crazy when I was being crazy. But that really helped, was to have somebody. I called her my mind therapist, because I would go in once a month and be able to whine for an hour and not feel like I was burdening it. That was really, really helpful.
I'm so happy to hear you say that. And as you're talking about it, you're smiling. And it's nice to have that objective person that then you walk out the door and you're like, oh, I feel relieved.
Well, get a reality check.
Exactly.
Am I obsessing about something I shouldn't be?
Sure.
Or is this a real issue?
Sure. And the discipline of the person, was she an MSW or a
licensed social worker.
Okay, which is very common. MSWs, and I happen to be a MFT, which is a marriage and family therapist. So we're a little bit different in that our focus is definitely more concentrated on family systems. And social workers are broader to understand more about social systems in general. So either person, there are different clinics that hire either MSW or MFT, depending on what their mission or their population is like. But truly a family therapist or an MSW with family training has a very different appreciation of how to establish balance within the family system. So both my degrees are very, very complementary. As an OT, I look at balance and occupational participation. And then as a marriage and family therapist, I look at the family structure. Very much how you heard persons here all talk about the physical body and the balance within those systems. I look at the balance within a family structure. And if the studies are saying that the family and your social supports are among the most significant variables for your change, then engage your family and bring them all in. And hopefully you'll find somebody, practitioners, who are willing to say, I'd like, my significant other to attend that session with me. And that should be a given, because that is your social support. And we're hearing this more and more. I think, as OTs and PTs, I think we've always appreciated that people in our clients' lives have that role of significance and have invited and have included them. So adaptation, how do we adapt? So this is what the outcome goal. So the literature describes that a person with adjustment shows these traits. You tell me if you agree, or if there's any there that pop out at you, or any that sound confusing or you wonder about.
Some of the posts that I read that were posted by the patients, what really spoke to the satisfactory participation in all desired aspects of life. There seemed to be one that a lot of people commented on, that they were no longer able to do the things that they loved to do.
Did everyone hear Carolyn's comment? So I read in the listserv as well, and I was also looking for the responses about activity participation from an OT perspective, but I was also thinking on this other level. And so what about that? How have people come to learn how to cope when you're no longer able to do things in the same way, or, as a progressive, have people talked about that with anyone, or is that a significant issue in the course of your adjustment? Has that come up at all for persons?
I'm not sure I understand your question entirely.
So the concern about I'm not able to do what I used to do. I'm not able, and I'm worried about it, or I'm anxious about it. Has that been an area of concern for people along the way?
For me, it's been so gradual that, you know, when I was 20, I made this adjustment. When I was 30, I made this little adjustment. At 40, so you almost don't even notice it. One of the issues, though, that I did work with the talk therapist was actually the third one, acknowledging limitations.
Right.
And some coping tools for that, because at some point it does hit you that, oh my gosh, I can't do stairs anymore. For a lot of us, I think it creeps up, especially if you've never had surgery, it creeps up on you slowly. It's not the car accident or the, you know, I had surgery last month and now I got it, but it's very, very incremental.
Right. Would others agree? I heard others say that that third item down, acknowledgement of limitations, it ties in. And so have you found a way to help yourself through that? Anybody have some words of wisdom around that?
And that's where you need to pull to get strength from number 2.
Mm-hmm. Okay, so sharing maybe some of the responsibility and
Evaluating what you do have and being appreciated for those strengths.
okay. So changing your perception and understanding that there are things that are meaningful and important that you can still do. And relying on another person or assistance is okay. So the wave of rehabilitation, as you've heard, is about enabling, not disabling. So it's independence with assistance. So assisted living didn't even exist like 10 years ago, right? But everyone in an assisted living facility is independent. They just need different levels of assistance. So a reframe like that sometimes helps us to put in perspective that understanding and appreciating our limitations is a human condition, normalizing that, and not minimizing your experiences with that, because again, that would get back to someone telling you that don't worry about it, like as if that's magically going to go away, but that the limitations in your life are your challenge. There's an opportunity for you to look at other alternatives, engage in different activities in different ways. Hopefully there's practitioners who can help to compensate if that's needed, without you feeling like you're at fault or that it's because of you. I think there's a need very often to separate, because very often our identities, who we are, is defined through the disability. And that's where it gets really hard. Would you like to talk about that? Sure.
I have a kind of a question. Sure. Most everyone I've met at all of the XLH days, those who are affected, the patients, have a very strong dynamic personality. Okay. And to me, it seems like that's our way of making it through life. What I'm asking is, are there tools, do you have tools that you're going to present today to help us when all of a sudden we have a really depressing day and we're not really sure how to get past that sort of thing?
Okay. So we'll talk about coping. Let's hold on. Don't let me slide on that one, okay? We'll come back to that. Let me go forward a little bit more. So rehabilitation studies are out there. So if you are encountering or you're talking with somebody who says, oh, don't worry about it, it's just part of life, that's not true. There is a unique reaction that goes with XLH that probably has not been studied. I have not actually found any literature or studies about the psychosocial adjustment patterns to having XLH. What an opportunity, Carolyn. And this may be something, to study. That's not the case with some of the other disabilities that are common. For example, spinal cord injury. Okay, spinal cord injury. So now one day I have all this ability and the next day, oh my God, it's gone. That shock value, that denial that ensues following getting that information that I have weakness or paralysis is so overwhelming that studies show that people tend to stay a longer time in denial if they have a spinal cord injury. It's just the nature. What you're telling me is this is a slow progression, so maybe denial is not as significant a psychosocial reaction as, something as sudden as a spinal cord injury. So that's what's unique. And there's not a panacea. There's not one coping strategy that fits all. It really is appreciating and understanding that. Persons with cardiac concerns, cardiac diseases, they tend to have increased anxiety. Why? Because when we get excited and we start to breathe faster and our heart races, or if we get scared, we get really anxious that we're having a heart attack. The symptoms of anxiety mimic the symptoms of having a heart attack. That brain is going click, match, match, match. So there are actually ways that we can help our clients to understand it is part of the natural course of things for you to be having some of these expressions, some of these reactions, and it helps to normalize that for persons to know. Again, I don't know that XLH has been studied in this way, but perhaps this is something, for the future to really understand it. I think when you talk to each other, you compare notes. You know each other's stories, and you're nodding, and you're saying, I've been through that. I know, I've been there. That's, in the earlier stages or in the later stages of, my progression. And so you probably talk with each other and share that information with each other. So it would help at some point to make that more explicit, to write that down. So having a chronic illness actually really speaks to, different points of view. So people have different interpretations of a disability, but it's very hard to just shake it off. If there's a short term, I broke a bone and I'm going to heal, we kind of work that through. But when you have a chronic illness, it's there. It's always there. And what's also really important is societal's view. So this goes back to your question about bullying and how children may not have tolerance for anything that is different. And it happens earlier on. And so that really shapes a child's experience. And so would an occupational therapist be involved? If the child in school got to the point where they couldn't participate in their activities and it impacted learning, I would hope that an occupational therapist would recognize that as something that needed to be done. There are protocols. We do run groups. As OTs, we're trained to do a lot of group modalities, and running a group with children on, tolerance and acceptance is a way to cope and to deal with that. In our program, we have a service learning project that's called Kids on the Block. They're actually puppets that come with, has anyone seen it? Seen a little act, a little stage show? So it's to enhance disability awareness in children. And our OT students, along with one of our faculty, go to different schools, kindergartners, first and second grade, and these puppets each come with a script. They come with a disability and they come with a script. And it's like a little show and tell. And so this puppet talks to the audience, kindergartners, first and second graders, about their disability. And then there's an opportunity for the children to ask questions and to participate. And the children talk to the puppet as if the puppet is real. But it's a way to advance this disability awareness as we're talking about the societal views and touching on that. So that is a link with occupational therapy there, and it has been part of a program that we have run as an example. So we cannot minimize those early on experiences that we have had. We can be adults and still be carrying some of that shame and embarrassment. And again, I would hope that if you disclose that to a practitioner, that someone would validate you that experience is something that has really, stayed with you many, many years, and it's something to work through. And anybody, right? Anybody kind of like validate that can happen. And that happens to a lot of us for different reasons. But just because we're older doesn't mean that we forgot what it was like to be the 9-year-old in pain, or the child who was ridiculed. So hopefully those are experiences that you could talk more about. So does everybody reach adjustment? No. There's many pathways. Everybody's disorder is unique. But hopefully people come to a place of balance and where you feel you're in your best state of mind. And if not, it's okay to ask for help. That again, this psychosocial phenomenon is something worth paying attention to. So there's been lots of studies, as I said, and ways to help us understand what is psychological recovery. So there's so many factors here that go into this, including your personality. And someone, as you were saying to me, we're strong-willed personality. So I don't know if that means you're type A's or, I'm a type A. So, type A's can be really tough on themselves. So there's some studies that actually say a temperament, like a personality, a type A that's very critical and very hard and perfectionistic, sometimes they struggle to adjust because they are so rough on themselves. If that could be channeled into, I'm going to motivate myself, do the best I can, I'm going to really not fight against myself, but I'm going to advocate and I'm going to make the best out of everything and channel that anger or that drive into something positive and productive, it can really work wonders. Sometimes we need a little bit of guidance and tweaking to know how to do that, to not turn that inward, to not turn that against ourselves, but to make it work for ourselves. Does that make some sense in that way? So anger in and of itself is a normal emotion. It can be very productive. It can also be very destructive. The productive way is to channel and say, I am going to fight for what I want and what I can do, and I'm going to persist in that. And I'm going to be realistic and fair to myself at the same time. And those are the responses that we listen for. When someone says, I recognize that I can do this really well and I need help with this, that's a realistic appraisal. That's a realistic review of themselves. In and of itself, that's a coping strategy right there. To be able to accept that and live by that and not feel like a failure or feel ashamed or embarrassed. Those are elements of the human condition that we hear across any, concerns that people have. Okay, so I want to show you a little bit about these stages. So this particular group, Livna and his colleague Antonek, came up with a model to help us understand what stages of recovery are like. So I don't know if anybody could speak to this, but when a person is in a situation where they learn or they receive a diagnosis, or perhaps you were told that you needed surgery, or you were told that your condition has worsened and you weren't something, any of those scenarios can trigger a feeling of shock. And then the anxiety of, what does this mean? When am I going to be able to do that? Future anxiety. Is that something that people have experienced? Some shock or some anxiety upon getting news or upon going to doctor's visits? Or is that something that people have experienced in the room at different times?
Not with XLH necessarily.
With other aspects. Okay. So when persons have more of as you said, a progressive and a congenital, this is something that eases over time. So it's a different experience. However, as parents, I ask some of you, was there a shock value perhaps upon hearing that your child had this diagnosis? So the caregivers go through the same stages very often as the person with the disability. And if I could also help you to understand that. So we always feel for our children in a way that's really unique. And so it is very important that you receive the support as well as caregivers, because we are at greater risk as caregivers to persons in need. And so we become a little bit more vulnerable ourselves. So that is something, again, another reason to perhaps engage a practitioner, an occupational therapist or a physical therapist to talk about, I want to share with you what my concerns are for my child. And I would hope, again, an OT or a PT would not minimize the mom, dad, or, as a caregiver, your experience, because that is so important. You are struggling and going through these stages at the same time. Bargaining and denial. So are any of you recognizing that some of these are like stages of grief and loss? So you may know the stages of death, right? Kubler-Ross. So in fact, Livna and Antonek used that model, okay? So now, some people can criticize this and are quite offended and say, why is disability associated with death and loss? Where are the studies that show the resiliency of people and how, the ability to overcome the resiliency factor and how bonds are actually tighter in families when a person has a condition? There's some of those emerging. Finally, people are getting that sense that they need to study the positive effects as well. But most of the studies that are out there are about the negative implications of having a disability. So bargaining and denial, let's talk a little bit about that. I don't know if anybody has experienced the bargaining. It is about your mind and soul. You're really asking for a trade. It's a way of a person trying to cope in the moment with the pain of the realization of recognizing that they have a disability and the implications of that. Denial is a really interesting defense mechanism, because in some of the disability or the disorders, when a person's in denial, they work the hardest in rehab. And so as they're saying, I'm gonna beat this, I'm okay, I'm gonna show everybody that they're wrong about this, they are driven and they have very productive outcomes in that. However, if denial lingers over time, it serves to minimize, right, ourself. So as you pointed out, you start to lessen your own experience. And underneath that, you feel like you're not perfect and you're not good enough, and those kinds of experiences set in. So the reason why denial is there in the first place is to help us with anxiety. So somewhere, if you are sitting, a colleague or a peer, and they're in denial, the thing not to do is to confront them and say, you have this disorder, or did you hear what the doctor said in there? I don't know if you've been on the other side of this, because when a person's that anxious and we confront them, what happens is we get more defensive. We actually put on more armor. So to confront somebody in denial is asking them to go further into denial. Have you had that experience with anybody? So what is the way in? What is the coping strategy? Is to empathize. I understand. Yes, there was a lot that was said in that doctor's office. You're right, this is so confusing. And maybe you're right. Maybe your experience with this is not going to be as they describe in the book. Try to validate the person's feelings and experience around this. Believe me, the reality will come, right? The person will, as they engage in therapy or as they try to do things, they will recognize that they have limitations. They will come to it on their own. But to confront somebody and try to get them out of denial works in reverse. Okay, so when I see somebody who's in denial, I know that they're anxious underneath. So as they start to break through the denial, the anxiety is going to come up. And now we have to cope with the anxiety that's underneath. So let's talk about the depression and the anger. Very normal. Okay, so what this does is it helps to normalize that these are feelings and reactions that we could all expect. So the next time you're sitting next to somebody and you're having a conversation, you can normalize and say, I too have felt very sad at different points in my life. I would hope a practitioner would say that to you. So when does depression become of clinical concern? Depression can be related to the coping and understanding the loss and feeling sad about that. That makes total sense. That's a reality check right there. That's not someone who's crazy, who's feeling sad or depressed because I'm not going to be able to do things as well, or I'm going to have limitations going. That makes total sense to be sad about it. When that depression, that sadness permeates all other aspects of their life. To feel sad about one's condition and the loss of functioning makes sense. When that sadness permeates everything, someone tells a joke, you can't laugh about it. You don't have the energy to laugh about it. Now you don't want to do the things that you found pleasurable before. Then we know that it's sort of moving away from just the psychosocial adjustment. It's now permeating into other aspects of your life. And depression is, as they're predicting, as they're saying, by 2020 will probably be the second most, this is the predictions by World Health Organization, the second most common disorder in the world. Okay, so we shouldn't be feeling ashamed about talking about depression. It is very, very common, and there are wonderful coping strategies and medications to help and to work this through. But it's an expected phase in the adjustment. Anger has two prongs. Anger turned inward, I'm to blame, I'm not good enough, I should have known better, it's my fault, I passed this on to my child, okay? That kind of anger can be destructive because it's definitely that turning, and it's almost like you are invalidating yourself, okay? So people get stuck here between the sadness and that anger that gets turned inward. They can stay stuck there. This is a very painful, painful place to be. And actually one feeds the other. My sadness, the sadder I am, the angrier I get and take it out on myself, the more sad I become. So this is a cycle that some people can get stuck in, and seeking help and assistance for this stage is very important. Retaliation, the fight. Okay, so if you're a type A personality and you are a fighter, now we're going to try to find a way to make this productive. What's not productive is to blame and get angry at everybody else for what you got. And so again, if you're a caregiver, a significant other, I'm sure you've been there. Right? So, you're upset and you're irritated and you take it out on somebody else. We've all done that for different reasons, correct? Well, if this is a passing phase, okay. But again, this is not a place to get stuck because family relationships get damaged here. So if this significant, your loved one, becomes the source, your punching bag, then that's clearly going to have an impact on the relationship piece. Better to go find a talk therapist and to lay it on them, right? We recognize that. That's the place to go and project, and then there's other activities that we could do. But that's part of the benefit of going into a neutral zone with a place that you can say what you want to say and not worry about hurting their feelings and damaging them in that way. So that could be another reason to approach talk therapy. So we have to turn this into something more productive. So how does this get done? And I'm going to talk about some of the coping skills. A lot of this is your thinking self. Emotions are not logical. So when you say, I am really angry, I'm feeling really angry, you have to honor that. Okay, so how I help you to cope with that is not to tell you to stop being angry. It's to learn what that anger represents and how to change that, how to cope with that anger in a productive way. So dismissing feelings and disregarding feelings, if it was that easy, we wouldn't even need therapists. If it was that easy. Just don't think about it, just don't feel it anymore, just cut it off. That doesn't work. Okay? So it is a change in the perception. It's the way we perceive, the way we think, what we believe. Okay? And this is what a lot of cognitive behavioral therapy will bring. Now, in the earlier stages of adjustment, people don't want to be told to change their beliefs. They want to tell you how bad they feel. and they need to do that. So you have to know when these coping strategies are best. If someone is just told that they have a diagnosis and they're just trying to come to terms and understand and they're anxious, they're not going to want your advice about, how to change their perception or who they are. They're not ready for that. Allow the expression of feelings. Allow the expression of feelings in a productive way. Ultimately, as you said, who am I? It's the redefining of who I am. That's how you know you have reached a place of acceptance. Okay? So, let's talk about coping strategies. So, as coping skills go, there are tools. So you've heard about a lot of the physical tools, you've heard a lot about the system tools, how to use a school system, how to engage with different practitioners who could assist. Coping skills are a toolbox that we could call upon, and they can be learned. Okay, so if you don't come equipped with them, we could still learn them. And that's important, I think, in that hopefulness that we need to feel. In the beginning, as we're struggling in earlier stages, we tend to avoid. I don't want to talk about it. I don't want to talk about it. I don't want to talk about it. When someone says that to me, I can't push them. I have to say, what do you want to talk about? How's life? Let's talk about what you're doing, who's important in your life. We could talk about your life, and that's the best way to engage in that conversation. Not necessarily to focus on the condition, but tell me about your life. What's going on? Let's start there. Education's really important in these earlier stages as well, because the more that I can learn, then I could begin to try to understand, and I have to assimilate that to myself. So you've got to give me some time to work on that. The coping skills of being goal-directed and knowing what I want and being able to go after it and getting the support, all of that, those are called problem-focused. They're problem-seeking. So as people go toward more adjustment, they tend to talk more about how they're going to solve the problem. They tend to be less emotional about it. That's a sign that the person is sort of moving toward this adjustment. They're not as emotionally trapped. They're feeling like, okay, tell me what I'm going to do. All right, I'm ready. Bring on the adaptive equipment. I want to meet with an occupational therapist. I want to meet with this practitioner. I want to get to know. I want to talk to my husband, my wife. I want to talk to my children about this, what I'm carrying this around and feeling very much to blame or upset about it, and I want to talk to them about it. Those are really good signs. That means the person is looking to solve and trying to seek ways to manage. This is not about fixing, it's about managing. Okay, so we listen for signs of that. So coping strategies have to be the right fit. Just because the literature tells us that these types of coping skills are better matched at different points doesn't mean that it's the right fit for the person. And I think that's where, going back to your point, is that how do I know? You have to try it. And if that one doesn't work and it doesn't have meaning for me as a coping strategy, then I need to find another one, and it's okay to admit that. And again, just like you're hearing other people saying, if you don't have a therapist or you don't have a confidant who's able to accept that you're frustrated and things are not working, then they're really not listening. And I would say find another therapist, find another person to talk to. So changing our view, our beliefs, health beliefs, looking at perception, how you feel about disability yourself, your own view in society, your own disability awareness, those are incredible conversations to have. Really important ones to have, because you are influencing others, and of course, you're representing yourself in those conversations. So social support. Cannot underestimate the need for social support. This truly helps us all in our adjustment of recovery, of any kind of recovery. Drug addictions, this is one variable that's coming out stronger and stronger in this. So we need to cultivate, as practitioners, we need to invite, we need to look for, we need to help you to make those anchors and finding those social supports, those persons that you count on and that you feel you can be really honest and be yourself with. And to recognize that that is something that as human beings we all seek. Social isolation is a risk factor. Social isolation. Me, myself, and I don't need anybody, I don't want to talk to anybody, I can't trust anybody. Those statements are of concern. Those are indicators that the person's more at risk of developing depression, for example, or the anxiety. So we're looking for people who are willing to adapt. The family adaptation. Cannot underestimate the role of the family. And so the studies are also saying that families with children and or significant others, whether it's a spouse, there's many different ways to describe a family these days, the family's at a higher risk, the whole family. So the whole family needs support. The whole family needs assistance. And again, hopefully not being ashamed to ask for that. So a family therapist would look at the family as a unit and help the whole family as a unit to strengthen itself. What do you all need? Do you need resources? Do you need a place to vent? Are there conflicts within the relationships that we can look at more closely? What will help you? Are there breaks, meaning leisure breaks that you can take? Sometimes we try to be too close. Being too close all the time can also make us bounce away from each other. But a little alone time doesn't mean that I'm isolating myself. It means that I'm regrouping. So family therapists can help to put some of those things in perspective. If you are a caregiver of any disability, okay, lots of studies showing that, the sandwich generation, caregivers in and of themselves are a risk group. So depression is much higher in persons who are caregivers for others. So I'm sure that some of this is already known to you. It may be just validating some of what you know. So where do we see these studies going? Looking at the positive and the strength and the resiliency of families and persons who have experienced disability. There is a unique aspect, and we're really trying to understand what that is. Really hard. It's not like, a mechanism where we could measure your strength. What is that component about that personality that person's so resilient? If you're a resilient person, you got it. No one can take that away. And you have this ability to cope with and understand things in a very different way. So we look for those resiliency statements. I can overcome. I know that I'm not fully to the degree that I want to be. I can't do it as well as I used to be, and I'm okay. That's what we're listening for. I can handle this. It's my preference to be able to do more, my preference. Okay, but it's not all of me. I am a person with a disability. I am a person first. Those are statements of adjustment. Those are statements of adaptation that we listen for. So seek help. I think there's very powerful ways if social connections, family, social supports are being shown to be one of the main variables here in adjustment, whether that social support is a therapist, whether it's, your best friend or your spouse or your parents, whoever that is, to seek support. Don't feel that you have to go through this alone. In and of itself, it gives us a sense of hope. I would also hope that rehab professionals who are trained, rehab counseling, and or MSWs or marriage and family therapists. I've worked with many, many families who have children of different disabilities, and I know particularly some of the themes that have been important, particularly for the moms and the dads, is the shame and the guilt that they inflicted something, they passed something on. How do they work that through? Do they overcompensate? If there's siblings in a family unit, does one child get away with more? Are the rules different, the discipline rules different, because this child I feel sorry for, and this child, you've just got to toughen it up. Those are some of the things that unbalance families, naturally speaking, but they're not uncommon themes in families that have unique situations to cope with. So let me just invite you to offer any thoughts, comments, questions for me.
I just wanted to comment
Sure.
that one of the things that I see in my practice is that people who have pain often will say to me, they don't understand because you can't see pain. And so people will say, oh, they can't tell how much pain you're in, versus my clients who've had a stroke, you can clearly see one side of their body's not working, or somebody has a spinal cord injury, you can clearly see that. But what I hear a lot is because I'm experiencing pain, people don't think of it as important or as a disability or as disabling in some situations. And they just say, get over it, move on. And so I think we do have to justify that, yes, I have pain. And hopefully a therapist will justify that yes, I understand you have pain. Let's see what you can do functionally within that comfort zone. And we heard Keith say that you want to do exercise within your comfort zone. But psychosocially, that's a big complaint that I hear from individuals. My family just doesn't understand that pain is just as disabling as not having use of one side of your body at times.
Absolutely, and the studies are backing up what Katie's saying. So the disabilities that are more visible to others, the persons have a lot more of those social negative stigma issues going on, and it tends to be more of a risk factor to developing depression because they are getting those negative views from people. You look different, you look different, you look different. Whereas the invisible ones, the person very often feels, as you said, lessened. They feel invisible. You're not recognizing me. So either side of that has its own implications needing to be talked about. Yeah. Did this make some sense in terms of relevancy? I think it would be a wonderful outcome goal, to study and to try to understand what some of the reactions are specific to XLH. I don't know that they exist right now, but they do for a lot of other disorders, as studies go. But it would be really interesting to know more about that. Are there other questions for any of us, or Carolyn driving it home? We're taking it home here? Yeah, this is the last?
We're all pretty tired.
Yeah.
As you mentioned, if people want to use some of the adaptive equipment or want to see the adaptive equipment, that's fine. Otherwise, I want to thank everybody again for attending. It was wonderful to see everybody and to have a live audience, and for you guys to be able to interact again with each other. I think that's really a very important component of the sessions. I want to thank the organizers. I want to thank everybody who's helped out. A lot of hands went into making this day a success, as well as my professional colleagues and then my new colleagues at Quinnipiac University. I'm very blessed to be in a complex where we are all universally housed together and able to work together. So this has been a very exciting day for me. And I hope you all learned something today. I hope you had your questions answered, and I wish you all the best. Thank you so much.